All right, so it is 10 o'clock sharp. We're going to go ahead and get started. All right. I hope you guys enjoyed that video. But thank you all so much for joining me for today's session as we explore how COVID has changed how HIM professionals are operating in their respective spaces. Special thanks to our event sponsor, The Qualified, for their unwavering support in making this happen. The Qualified is a certified women and minority owned employee and employer support service made up of experienced HIM professionals helping new and existing HIM professionals become credentialed, maintain their credentials, and find their place in the industry. So, some of you I have seen before either on LinkedIn or I know personally as colleagues or friends, but I wanted to take a moment to formally introduce myself to you before we got started. So, I have been in the HIM industry for more than 10 years with a background in revenue cycle, release of information, compliance, patient access, and information governance. I've dubbed myself as the HIM concierge because I'm a great connector of people and I enjoy helping others get the resources that they need to be successful. My love for the HIM industry and my passion for helping people led me to become the founder of HIM Concierge Services, where I help students and professionals along their career journey through certification prep, resume and cover letter revamps, PPE placements, and accountability and coaching. I help make sure that KHIM accredited institutions are properly preparing students, and I support employers by helping fill their HIM talent pipelines. I'm also passionate about health literacy, patient advocacy, and Bobby Brown. One of the reasons why I decided to create this space with this type of format is because I see the need for it in more ways than one. Not only because I'm a Black woman and we don't typically see that in this industry, but as a professional, it would have been nice to have a panel like this to help me decide how I wanted to pursue my career. I can't say that I was purposeful in how I traversed the industry and I just kind of rolled with whatever I was qualified for instead of really leading with my passion. But I'm hoping that this series, because there will be more than one, will help to fill that gap for you and future HIM professionals. So, this program is going to be for you if If you are a student or you're new to HIM, this is going to give you some insights into what work within each of the domains looks like. If you're looking to make a transition, it might help you to see how your skills could potentially translate over to a new domain. And if you're an instructor and you've been removed from the industry for a while, this can help you decide if what you're teaching is really matching up with current industry standards. So to give you guys a little bit more background, AHIMA has determined that the HIM industry can be broken up into four domains: revenue cycle and coding, information governance, data analytics, and healthcare informatics. So today we're going to speak with amazing panelists that represent each of these areas so we can learn about what they're seeing in their respective areas since COVID. And we're also going to speak about the credentials that you may wish to pursue within each of these domains to help you in your careers. So here is a brief agenda for today. So for the first hour, we're going to speak with Lakeisha Moore. She's going to speak about revenue cycle and coding, followed by Terrence Sherrod, who will speak about information governance. Then we'll have our first breakout session where we'll hear from Dr. Sabri and learn about certifications available in these areas. And then we'll follow up with a discussion about data analytics and healthcare informatics. We'll follow that up with another conversation with Dr. Sabri. We'll have time for questions after each panelist, so please feel free to interact with our panelists either by coming off camera or entering your questions in the chat. We're going to have a few giveaways throughout the event based on winners of our interactive quizzes. And firstly, I wanted to get a feel for who we have in our audience today. So here is a quick poll that should pop up on your screen soon, where I would like for you to choose how you would best describe where you are in your journey. Are you new to the field? Are you an instructor? Or are you an experienced professional? Okay, so based on the results of our poll, we see that most of you are going to be experienced professionals, so that's great. So again, if you find information within this presentation and you feel that it can help you as you transition to another role, or if you just want to learn about the different areas and what they're doing, because sometimes we can be siloed when we're working in our respective spaces, this is going to be a great presentation for you. So let's go ahead and get started with our first guest. So Lakeisha Moore is the Director of Coding and Operations at Parkland Health and Hospital System. At Parkland, she is responsible for coding operations for both hospital and professional coding. She has over 20 years of HIM and healthcare experience to include leadership, compliance, HIPAA, HIM operations, including recovery, audit, contractor, clinical documentation improvement, and hospital coding, informatics, and project management. She has a bachelor's degree in HIM from Eastern Kentucky University and a master's in business administration, which she obtained from Sullivan University in Lexington, Kentucky. As an administrative fellow, she gained experience in hospital operations and human resources. Some of her proudest accomplishments include decreasing the discharge not final bill from 33 million to 7 million, successfully implementing an enterprise document imaging solution, and leading a successful ICD-10 implementation. She is a past president of DFW AHIMA and professionally affiliated with American College of Healthcare Executives, Association of Clinical Documentation Improvement Specialists, American Health Information Management Association, and the Texas Health Information Management Association. Everyone, please welcome Lakeisha.
Thank you so much for inviting me to share how COVID is impacting the revenue cycle and coding. So let's first take a look at how the pandemic is impacting our hospital. First and foremost, we know that hospital reimbursement has been significantly impacted from the pandemic. Initially, we saw a huge negative impact when we had to postpone and, in some cases, cancel all elective procedures. So, we had to make some adjustments to sustain operations during that time. The great news is is that Congress adopted several policies to help ease the financial strain healthcare providers are seeing and continue to see since the pandemic started. These funds are intended to help alleviate the revenue loss we are seeing due to postponing those non-urgent procedures and non-urgent care, along with just the sheer impact that COVID has gifted us. So, on a positive note, which gives all Medicare enrolled healthcare providers grants that are roughly around 2% of their previous annual patient revenue, which is awesome. A portion of that funding from this program helps to support related expenses such as COVID testing and treatment. And this is just one example of the programs available for healthcare providers, and also one of the reasons why we have free testing and vaccines available to all. Another program or entity is called HRSA, and that stands for Health Resources and Services Administration. And what this program does is it provides equitable health care to people who are geographically isolated and economically or medically vulnerable. HRSA has claims reimbursement programs for healthcare providers and facilities, which offers us reimbursement for uninsured patients receiving COVID testing, treatment, and vaccine administration. Now, as a coding leader, one of the issues that I have with HRSA is that they do not have to adhere to HIPAA requirements because they're not considered a health plan. So what that means is they don't have to abide by the coding guidance that we have to, nor do they provide us any coding guidance for submitting claims. But they do, however, provide some billing guidance to allow providers to identify and submit only claims for eligible reimbursement under their program. Now, eligible means that they will only reimburse COVID testing and treatment for the uninsured only when COVID is listed as the primary reason for treatment, or for vaccine administration for those uninsured individuals. So we have a pregnant patient, a pregnant woman who presents for delivery with COVID. We know as coding professionals that the pregnancy code must be listed first and the COVID code would be listed second. So initially, HRSA would not pay for claims with COVID listed as secondary, which caused a lot of issues in our industry on how one should submit claims to be paid. Now, guys, what's crazy is that, I heard some revenue cycle leaders talking about this and talking about, the best way to ensure that we get reimbursement from HRSA for those claims when we know, based on coding guidelines, COVID can't be listed first. But again, like I said, HRSA doesn't care about coding regulations and guidelines. So, of course, I'm not going to name any names or state any organizations that these leaders were from, but, some people were even considering just assigning COVID as the principal diagnosis. And then once they got reimbursed, they would go back and change those claims. Not only is that laborious and crazy work, it's also unethical. One of the other impacts that we've seen is related to digital health and telehealth. So when CMS announced that they would reimburse for telehealth services during the public health emergency, this really expanded our ability to provide care to all. Now CMS has made an initiative to expand remote healthcare access to rural America. So Medicare has made those 9 telehealth services, such related to psychotherapy and some cognitive imperatives, permanent. But they also plan to extend to 59 more services. Emergency department or critical care, and even for some of our PT and OT services, we can now, or we will be able to continue to provide those services via telehealth post the public health emergency, which is phenomenal. As we continue to look at these impacts, one of the other things is, we've had unpredicted fluctuation in our volumes. So, as mentioned before, when we had to postpone our non urgent care, that really put a dip in our hospital volumes. And so then we had a dip in the pandemic in COVID volumes. And then we got another peak of COVID cases. So, volumes just fluctuate all over the place. And so when that happens, it's really, really, really hard for us to plan and project what our financial impact is. Even though we're receiving funding, we're still trying to ensure that we can provide care to our patients and be able to plan. And we all know how we plan in hospitals. We plan based on our admissions, our discharges. And so with all of this fluctuation
Okay, you guys still here?
in our volumes, it's really put us in a place where we can't plan. So one of the other things that we're seeing is the constant changes in our regulatory environment. We see new coding guidance and new rules related to billing, and a lot of different regulations are coming out around COVID and how to treat. New vaccines are coming out. So there's so many changes that we've seen in our regulatory environment. All of this tied into a neat bow keeps our AR very, very high. And so, we're working to see how we can reduce our AR and ensure that we get paid. And during this process, we've learned how technically dependent we've become, and how having the proper technology in place can really help us. So we've been creative in finding ways to automate our pre and post collection services, looking for ways to get our claims out the door faster, cleaner, so that they don't come back. And more importantly, we don't receive a denial on our claims. So, we've had to become very, very creative throughout this process. So, another thing we've seen that has impacted our revenue cycle is, we've gone to a remote workforce. Back in the day, you know, that this was unheard of. People working from home. Well, how are you going to keep an eye on them? How are you going to ensure that they're productive? How are you going to make sure that they're working? But with COVID, we had to go to a remote workforce, have our employees working from home. And for months, we did this. Now, I know at Parkland, we brought people back on site, and a lot of areas have returned back to the office. But with the numbers rising again, who knows? We may see a remote workforce become the norm. Now, me personally, I never thought I would enjoy working remotely, but honestly, with the risk of COVID and making sure that we are implementing the best safety measures we can, I have really grown to enjoy working from home. Now, again, this concerns leaders because of, we were initially concerned about the loss of productivity, like I mentioned earlier, but we've seen that a lot of people are more productive and have proven to be more effective when they are working from home. And sometimes we tend to work longer than we should, especially if you're an exempt employee. You're not clocking in and out, you're not paying attention to the clock. I look up sometimes and it's dark outside and I'm still working. One of the other things as it relates to our workforce is we have seen, especially here lately, staffing shortages. So every organization has encountered this, but not only in healthcare are we seeing staffing shortages, we're also seeing it in retail and restaurants, and a lot of places closing or changing their hours, I should say, because they don't have people to come in and work, because so many people are getting COVID that is forcing us to alter our workflows and revamp our operations just to keep the lights on. So at Parkland, what we've done is we still have our labor pool where we're asking our non-clinical and clinical employees to work in other areas where needed so that we can continue to provide excellent patient care. So for example, I've helped out nutrition services. I've prepared trays to go up to patients because, we really need to make sure that our patients are fed. So that is a critical job within our organization, that when they're short staffed, we've got to have people that's able to come in and hit the ground running and really help out so that we can make sure that our patients are well nourished, they're fed, and we're still providing excellent patient care. I want to shift a bit and talk about the impact that telehealth has had on billing and coding. So telehealth has increased access to health care for the underserved and our rural communities. So as mentioned before, Medicare has historically placed restrictions on our geographic locations of individuals who want telehealth services until this pandemic. Commercial payers also had restrictions due to the concerns of fraud, overusage, and low quality of care. Both had restrictions on the types of services which could be seen via telehealth, as mentioned before. So another impact is our reimbursement and coding changes for telehealth. So I mentioned how we've had new codes and how our guidelines have changed, our reimbursement has changed, but there has been a significant expansion in our codes for telehealth as it relates to how we provide services such as via telephone visits with and without audio or video, also specifying the time spent with the patient. So we were also introduced to virtual check-ins or technology-based services back in 2019. However, we no longer have the geographic restriction we had then, and Medicare has temporarily waived the audio-video requirement for many telehealth services during the public health emergency. As mentioned again, there are many new billing guidelines and payment rates to use after the public emergency ends. But I don't know if you guys remember, but back in 2005 for Hurricane Katrina, CMS added a condition code and CR modifier to facilitate processing claims affected by an emergency. Since then, that CR modifier is no longer required for CMS to pay for that claim. So hospitals can bill Q3014 for originating site when services provided telehealth services registered as outpatient. So those services provided by the hospital in the patient's home, for example, as a provider-based outpatient department when that patient is registered as a hospital outpatient. So that's how this is how we're able to see a lot of organizations have home care now, because, we can bill those as a hospital outpatient, which is wonderful. So one of the other impacts that telehealth has had on billing and coding that's not so positive is, we've seen a lot of delays in our reimbursement, and that's for various reasons. So wrong codes, if we submit the wrong codes, we don't have that place of service 02 on there, and we don't have the modifier 95 on there, then we can see a denial. Also, if there's inadequate documentation, if the provider hasn't documented how much time they spent on with the patient if we don't have that consent form signed by if we don't have the consent form that is required. If that's missing, that can delay our reimbursement as well. And then also something called not delivering care in real time. Now, believe it or not, with telehealth, which is what had some of those payers concerned with this before this pandemic started, believe it or not, we have people and providers who don't provide care in real time and then try to store it and then forward those activities and submit them later. So we can't do that. And if that's identified, of course, that also delays our reimbursement. Now, what about HIM as a whole? What lasting impacts from the pandemic do we think we have specifically for our HIM profession? Well, I think we will continue to see a remote workforce. There are several organizations that when they sent their people home, they have not brought them back. And with COVID numbers fluctuating, depending on the time of year, and all the different variants this virus makes, it's so hard for us to plan and predict or even know what our future is. I think we will continue to see changes to our HIPAA rules as it relates to COVID and release of information guidelines, etc. And coding changes. If we continue to see all the different variants that we're seeing, we do see vaccines evolving, vaccination optimization. So, of course, as long as we have those things coming and going, we will continue to see changes in our codes. We'll get new codes added to the code set related to COVID. And I expect to continue to see, again, the different various treatments for COVID as well. Reimbursement and healthcare models. So they will continue to evolve as we try to keep our heads above water and avoid a healthcare crisis. Telehealth and virtual care. So I'm sure our millennials are happy about the expansion of telehealth and virtual health. Virtual health is here to stay. Virtual care is here to stay. And we will continue to see it evolve and expand as well. Those are all of the points that I wanted to discuss with you today. And now we're going to open up for questions.
All right. So first of all, thank you for your presentation and bringing up some of those issues that you've been seeing in your area. And I'm really thankful that the government stepped up in a way to keep hospitals afloat while still working out the kinks on how to get reimbursed properly. But I did have a couple of questions before I open the floor to everyone else. So you mentioned how HRSA has different guidelines for codes, and you gave the example of pregnancy not being the primary diagnosis, and those that are coded that way are denied. So in those instances, when you have those claims that are rejected, does a timely filing requirement still apply, or has it been extended due to COVID?
That's a great question. Thank you for that question, Shakira. Actually, the timely filing guidelines do still apply unless your organization has worked with the payer to update or change your contract, what's listed in their contract. So otherwise, the timely filing rules still apply. So,
Okay.
Okay.
So the next question I had was, to meet the workforce demands, because you talked about that also, what does it look like for new coders? They may not have the extensive experience, such as those of us, they may have CPCAs or CCAs. Is it realistic to consider relaxing that environment a bit, considering the shortages?
Well, there are actually some organizations that take those credentials actually, and there are even some that have apprenticeship type roles where they take coders through a coding boot camp or extensive coding training so that they can provide the type of experience that's needed and make sure that they're coding accurately. So for the most part, unless well, let me just say that my opinion is, for the most part, that unless you're already taking those credentials and have those types of programs, I really don't see a lot of organizations laxing their experience guidelines and rules, because it's a risk to do so. So you either have to have a good training program to take those coders through, or you need to hire coders with the experience that you need.
Yeah. Okay, so the final question before I open it up for anyone else, what advice would you give to HIM leaders as they're continuing to navigate department operations during the pandemic?
Well, working in this industry, we all know that we have to be adaptable. We have to know that the only thing we know is that change is constant. And so we have to be as proactive as we can by developing, strategic plans based on what we know at the time. So what I would suggest is brush up on your change management skills and be ready to lead your team with transparency. I would also say communicate often, and stay up to date what's going on in healthcare as a whole, and not just in HIM and revenue cycle. Um, and finally, get used to telehealth, because it's here to stay. And so, and I think that it's a great way for us to provide care to our patients in any area.
Okay, anyone else have any other questions? Okay. Well, thank you so much for joining us today.
Thank you so much for having me, Shakira, and everyone. I'm sure you guys will enjoy the rest of the education sessions here today. Thank you.
Thank you.
We
All
do
right,
have
so,
one
oh, go ahead.
question, and we've got one question in the chat. Potencia asks, do you anticipate home health will still be considered from a billing perspective? What telehealth when the emergency has passed?
So I think the question was, would I consider home health? Can you repeat that just so I make sure I answer?
Yes, absolutely. It's in the chat section, and it says,
Okay.
do you anticipate home health will still be considered from a billing perspective, telehealth when the emergency has passed?
Yes, I think it depends on the organization. So for example, say for example, a hospital had home health services department. So as I stated in the presentation, if you're a hospital providing home care, then when you register and bill that patient, you're billing them as an outpatient. However, if you're a standalone home health agency, that's different. So the billing guidelines are a little different, but that's the differences I see in a hospital providing home care, and then a standalone home care agency providing home care. Hope
Thank
that
you for
answers the
speaking
question.
to that. I appreciate it.
All right, anything else? All right, we're going to go ahead and move forward with our next presenter, Taryn. So Taryn is the president and founder of Bach 10 Solutions, and she specializes in regulatory compliance and health information consulting services. Taryn has over a decade of experience helping large and small organizations capture accurate and comprehensive clinical and revenue cycle workflow documentation, and she uses that experience to customize a plan for providers, scale to meet the metrics that support an effective compliance program, and transform and improve the quality and pathways related to denials, appeals, and health information. As an RHIA, CHC, and CPMA, Taryn links complicated regulations and standards to practical workflows in compliance, health information, and revenue cycle integrity. Taryn has supported healthcare providers as an HIM director, audit, denials, and appeal coordinator, internal auditor, charge master, senior analyst, new service coordinator, and compliance consultant. Whew, Thank you, Taryn, for joining us today. How are you? Can you
I'm
hear me?
good. Sorry, I was
Oh,
on mute.
okay.
So I'm good. Thank you very much, and thanks for having me.
Absolutely. So let's go ahead and get started.
Okay. Well, I'm going to talk to you again, examining the COVID-19 and HIM implications. Next slide. This is just my little disclaimer. This is based on my own personal opinion and experience and is not to be considered compliance advice. Next slide. So today we're going to talk about coding audits and how that's a valuable tool in the compliance program. And then how HIM and compliance relationships work together, and then being partners in privacy and information access. HIM professionals have such a unique advantage with their knowledge and skill set to forge alliances with other professionals in the organization, protecting the assets of the organization and enhancing the patient's experience. Next slide. So there is the Justice Department Department of Justice has put out a fact sheet on COVID-19 fraud cases, and pandemic relief programs have exploded with fraudulent activity. Misuse of the Paycheck Protection Program, exploiting COVID relief programs, fraudulent coding and billing schemes, loan applications, employment benefits, so far to the tune of over $600 million. COVID-related services are just ripe for risk and are going to be audit targets for all types of providers and services. So it doesn't matter whether you're large or small, the constant is fines and penalties hurt the bottom line and take valuable resources away from patient care. The links on this page take you to some details about the task force and provides links to articles about COVID-related crimes. For instance, a person purchased a Lamborghini after receiving $3.9 million in pandemic assistance loans. Another person fraudulently obtained $5 million in COVID relief loans, and many others were charged with fraudulent loan applications totaling millions of dollars, and the list just goes on and on. So in this case, the Department of Justice, the defendants were engaged in healthcare fraud schemes and exploiting COVID-19 resources. They were asking Medicare beneficiaries at senior living facilities and drive-through testing sites and medical office sites to take COVID tests. And they were inducing those beneficiaries to provide their PHI, their private information, and some saliva and blood samples. And then the information was misused. Those samples were submitted for as claims to Medicare for unrelated or not medically necessary or inexpensive lab tests. Things like cancer genetic testing, allergy testing, respiratory pathogen testing, and things like that. The COVID test results were not provided to the beneficiaries or their primary care providers in a timely fashion, and many times weren't reliable, further risking the spread of the virus. The criminals then laundered this money that they were paid through shell corporations and used that money to purchase exotic automobiles and luxury real estate.
Nice.
So in the spotlight for HIM and compliance would be COVID-19 audits. There's been unrelenting coding and billing changes that have challenged and challenges that are surrounding this pandemic. It's a long list of waivers and flexibilities that were issued during this pandemic, and all that change brought a lot of risk. Those changes affected HIM workflows. So HIM needs to make sure that policies, coding rules, and guidance materials that was used to code and bill COVID cases is easily accessible should oversight agencies and auditors want documentation of why you chose that particular code or that particular diagnosis during this particular time and during that change phase. And getting your hands on that information is important, and make sure you keep that documentation of all those changes that you did during those workflows. Audit your COVID cases to ensure that they've been coded correctly, they follow the coding rules and guidance. And there's some new COVID codes, as Letitia talked about, coming out in October. So the new long hauler codes apply to patients who are suffering COVID symptoms and have chronic conditions from this virus. Payers are going to tear this up by increased audit scrutiny. They're going to question that it's a truly long hauler disease of COVID or chronic condition of COVID and not just something else. Include these rules and regs, like I said, in your audit plan. Ensure that documentation is there to support the services and cite to any rules and policies that you used. E&M codes are also a high-risk area. The complex critical care codes are a target. Make sure your documentation supports the level of care and that you've used your modifiers according to payer guidelines. So these coding and reporting changes are just blasting at providers, and all of this fast change creates high risk. So as providers take in this information, there's just a really small window for them to train and assimilate and fit this information into workflows. So huddling on a consistent and regular basis in your department is a great way to ensure that that information is spread throughout the entire group. Next slide. Telehealth, as Letitia spoke to this also too, the OIG will be auditing billing patterns and the risks related to the waivers and the flexibilities and the Medicare and Medicaid beneficiary access to telehealth services. There's just a lot of moving parts with telehealth, which again increases all that risk. The communication, audio, video, encryption, information storage, transfer, release of information. Every aspect of telehealth needs to have some controls surrounding it. So privacy and information access. Medical data is like gold on the black market. Run test scenarios to detect privacy and access gaps. Find and fix the weaknesses. Learn lessons that make the process better and stronger. Audit areas like release of information processes, telehealth recording releases, storage and designated and legal record sets, timely release of requested records. Keep those on your radar and include them in your audit plan. Health information protects patient information and owns many of these workflows. And it would just be prudent to audit those areas and ensure that your organization is in compliance. So information access, the OCR has been cracking down on entities for HIPAA violations. Again, it doesn't matter if you're large or small, HIPAA violations will not be tolerated. And fines are based on the number of records compromised, but that can range anywhere from $120 per violation to fines that run into hundreds of thousands of dollars for willful neglect. The link on this slide here will give you some examples of common HIPAA violations. HIPAA violations are things like snooping in family, friend, coworker, or celebrity records. Again, in this link, you can read a story about a doctor at one of Los Angeles health systems was found to be snooping in the medical records of celebrities. His actions resulted in the health system he worked for being fined $865,000 for failing to have proper controls that restrict access. So one of the most important objectives of the HIPAA privacy rule and the HITECH Act was to ensure that customers had easy and affordable access to their PHI. Regular HIPAA audits reduce that risk. So addressing targets like collaboration between HIM, privacy, IT, and compliance can help reduce that risk. Then rank that risk when you do audit, rank that risk from high to low and tackle your high risk areas. Next slide. So now I'm going to talk a little bit about health information and compliance. My career, the first half of my career was dealing with a lot, was in health information as a director and coding and working with revenue cycle closely. Then I bridged over to compliance, and I brought so all of my skills from health information into my compliance job. So, excuse me, there are so many ways that health information and compliance can work together. Professionals, they have so much in common for achieving the goals of the organization, because both professionals use analytical skills, problem-solving skills, and critical thinking, and they pay attention to detail. Health information professionals are trained to look for documentation accuracy, timeliness, and quality data. They know where the data resides, where it's generated, and the life cycle before it's pushed out on the claim. Compliance professionals should have an annual HIPAA risk assessment in their work plan. And as part of that compliance work plan, they're reviewing PHI access, identifying privacy and security incidences, evaluating privacy and security measures, and looking for potential risk related to PHI. Again, much of this lives in the wheelhouse of health information professionals. They compile, organize, store, protect, and transfer enormous amounts of PHI. So when health information and compliance work in tandem together in these areas, they really put the organization at a strategic advantage. So here's the 7 elements of a compliance program. Standards and procedures, education, training, oversight, auditing, monitoring, reporting, enforcement, discipline, and response prevention. And I'm going to slip one more in there. I call it the 8th element. It's measuring effectiveness. So measuring what's being done in each of these areas to ensure that each element is addressed and the employees understand and are using these elements in their daily work responsibilities. The best way for HIM and compliance professionals to collaborate is to first have a one-to-one discussion on these department goals, and then talk through ways to meet these goals, and this becomes a win-win for both departments. So the areas that coincide are standards and policies and procedures. So audit alignment of the policies and procedures against the regulations and internal practices. Just ensure that proper controls are effective and that the dissemination of regulatory changes and training is happening. One of the other areas from the 7 elements is auditing and monitoring. So audit coding, audit PHI access, audit release of information, do a HIPAA audit, look at payer denial targets. HIM can perform regular audits of these department workflows and then work with compliance to analyze and track and trend and benchmark these results. And then reviewing and responding and gleaning valuable education from payer coding denials. Compliance can make sure measures are in place to refund overpayments in a timely manner. And then investigations with vendor compliance, performance metrics, and corrective action plans. HIM professionals are touching used vendors, used consultants, and are accessing a lot of software systems. So working together to make sure that in vendor investigations or vendor oversight that the vendor is compliant and is their work is complete, and the metrics that are outlined that are outlined in their contract or they're expected are being met and meet the organization's standards for professional work. If you run into issues with vendors, then work with your compliance officer to coordinate a performance improvement plan and the expectations if it should roll over to a corrective action plan. So a real quick recap of what we talked about is forging relationships with other professionals in the organization and working together to understand and implement these regulatory changes when it comes to your coding audits. Aligning workflows with the compliance work plan and tracking and trending and reporting gains and loss metrics that are revealed through audits, and then show where education and improvement have been effective. And then be a valuable partner in HIPAA audits. Implement an information governance plan to know where your PHI resides, what systems it lives in and the locations, where does it flow to and from, and how do employees and patients access that PHI, and who's releasing that PHI. Just knowing this information will help you detect weaknesses and fix them, and you'll just be a team player with making sure that the compliance work plan and its objectives are met for the organization. now I'll take some questions.
Nice. Thank you so much for that presentation. Can you explain the legal ramifications for that fraudulent coders, and specifically how it and what's at stake for coders?
Coders can face some pretty stiff disciplinary measures, as outlined in their HR policies and so forth. You know, they might get a verbal warning, always get some training, then and then it can roll over to a written warning and even termination if need be. If the coder is found to have made an ethical error in coding, then they risk losing their credential, and not being able to keep their credential as a coder.
Okay, so one of the questions I've always wondered, and it's kind of left field, but it's just something that's always bothered me. So when you're sending emails inside the organization to each other, should that information be encrypted?
No, it doesn't need to be encrypted. The most systems today, first of all, you're within the organization, so you're protected by the firewalls that surround the organization's internet and IT information transfer. A lot of people, where they get into trouble is they'll reply or send an email by, for instance, if I was to send an email to you and you worked in an office upstairs from me, then I would start to type in SH, and perhaps thinking that your name came up, but actually Sharon Jones came up or something like that. And then sending that information, and Sharon Jones is outside of the organization, and I've sent that information on. So a lot of organizations have encryption keys that are put in the subject line. So might be alpha or alphanumeric, but if you always put that in the subject line of your email, then your email will go encrypted. So, you know, and many organizations also have the feature that if there's a string of numbers that looks similar to your account number, or a patient's account number, or a claim number, that the system automatically encrypts that email. But it's just always safe. And even after 20 years, I have a little sticky note as I work with clients, but I did when I worked for employers also. I had a little sticky note with the encryption key stuck to my monitor. So I would just always see that sticky note, bright sticky note with the encryption key, and not forget to stick that in there. Many times, most of the time, I just start an email by putting the encryption key in the subject line and then writing the email.
Better safe than sorry to do it that way.
It is. Mm-hmm.
Yeah.
It is.
Any other questions for Taryn?
We do have a couple questions in the chat. Would you care for me to read them aloud, or
Yes,
Taryn
please.
or Shakira? I will
Yes.
go ahead. All right,
Sure.
so Whitney asks, how do you suggest dealing with providers who always document time so they can get a higher level? I've had scenarios where time was documented was a level 5, but if you read the note, the patient does not sound that critical. This is a pediatric clinic. We can't question the provider on time. I've also had an ER visit where the provider documented critical care time on a patient with a cold, COVID negative. Just wondering your thoughts on scenarios like these.
If it doesn't qualify for time, you know, there's got to be some education around that. Physicians don't know the coding rules, and those E&M visits, many of them do qualify for time, but when they get into some of those critical care areas, it's based on medical necessity. So I think that for providers, they're documenting their time because that has become an element of choosing the E&M codes. But I think that as a department, you need to powwow about how you're going to approach those, and then issue some education around it. Because if it doesn't meet the time E&M guidance, then you need to code the E&M visits appropriately.
Great, thank you. In the chat, Hope asks a couple of questions. The first is, and we've discussed it in a similar context, but what are your suggestions for vendors to make sure they are compliant and how they can go above board to show clients they are HIPAA compliant? And then she has an additional question that she'd like some feedback afterward.
Okay, so vendors, first of all, the contract should outline some performance metrics and some compliance expectations in the contract. If it's a contract that's already currently in place and doesn't have that, then you're kind of at the mercy of requesting that information. And you can request, if you're lucky enough to be writing the contract and negotiating the terms of the contract, then ask for quarterly HIPAA reports or monthly HIPAA reports or an annual HIPAA report. Ask for compliance metrics that not only align with your expectations from the department and what the vendor is providing, but also align with the compliance officer's expectations in the work plan. So that's where that one-on-one conversation can be really helpful. I've worked with departments and compliance officers over vendor oversight, and just marrying the contracts with state and federal regulations, developing a performance improvement plan, and then auditing that vendor on an ongoing basis, like weekly, on their product and their production, to report that, and giving them a deadline of when that performance improvement plan then will flip over to a cap, and their contract is at risk. They have to, a cap has to be reported to the board and the stakeholders in the organizations, their organization. So just making sure that you've got your criteria and your standards outlined. And again, ask for regular reports, ask for your HIPAA compliance reports, ask for productivity reports, ask for savings and loss reports. Just that's how I suggest that that vendors are going above and beyond to provide that. And if vendors aren't providing that, to let you know and touting how well they can help your organization, you probably don't want them.
Great. And the final question, if you have anything to add with your last statement from Hope, is there a standard way of communication between vendors and business associates to clients in healthcare facilities that you suggest as best practice for the work relationship, which kind of goes on to say what you were just speaking to?
I think that having a weekly meeting together with, and I've seen it where, and generally I'm brought in to help problem solve with some of these types of issues, problem solve for the provider, the struggles that they're having with their vendor. And so we set down the guidelines, we align them with the contracts, and we have a weekly meeting going over the expectations. I will do audits against those expectations and the findings of the product not being to the standard the organization expects, and just keep reporting that. And then the compliance officer is generally a part of that team. I've been in situations where the vendor has made improvements immediately, and I've been in situations where they haven't. We've had to roll to a cap. We've had to bring in legal, and there's been some serious conversations about canceled contracts or non-payment. So just setting those standards and then having a weekly meeting to address those issues is the best way to communicate that information.
Outstanding feedback. Thank you so much, Taryn. And that wraps up our questions in the chat. So
Thank you so much. Perfect. Thank you, Taryn. That was amazing.
Sure.
So next, we're going to hear from Dr. Kenja Sabri. I love her so much. So, a little bit of background on her before she gets started. She holds a Bachelor of Science degree in Health Information Management from DeVry University, an MS degree in Instructional Design and Technology from Walden University. In addition, Kenja completed her doctoral coursework in higher education, leadership, and management at Capella University. She earned her RHIT in 2008, superseding it with the RHIA in 2010. She earned the CCA in 2017 to share the experience with her students. And in 2021, Kendra became a member of HIMSS and earned the KHIMS credential. Over the years, she has held numerous leadership positions in health information management in several hospitals throughout the Tampa Bay area. She transitioned into education as an adjunct instructor for a health information technology program in 2011, and she transitioned full-time into academia in 2016 and found her passion for teaching, mentoring, and helping students earn their certification and secure employment. So welcome and thank you so much, Dr. Sabri.
Hi, thank you. Thank you so much for that warm introduction. This has been fantastic so far. So I hope everybody is enjoying themselves. In a way, I still feel like we're just getting started. Like my
Yeah,
heart is just starting to beat fast. I'm
yeah,
like, we're
yeah.
getting into the midst of it. So thank you all again for having me. I just want to spend a little bit of time talking about HIM certifications, about like surrounding the topics that we've covered so far. So first, revenue cycle and coding, and then information governance. So I'm going to take a moment here and share my screen with you. If you can allow me to share my screen.
Sure.
Perfect. Not yet.
Did I break something?
No, you didn't break any. You're still just not letting me share my screen yet. Hmm. If you make me the host again, it might work.
Sure. Let me see.
Okay.
Give me a second. I'm pulling that up.
Oh, no problem at all. So I'm not going to talk about a ton of certifications today. I am going to strictly stick to I want to say the big three, right? Like basketball. We're going to do AHIMA, AAPC, and HIMS. All right, perfect. So I am now hosting. Let's share my screen. No, not that one. All right, here we go. All right, can you all see my screen so far?
Yes.
Okay, so let me see if I can start this from the beginning. So this is our breakout session. We didn't have a breakout room simply because we are all together. So, okay. All right, so we're breaking out to explore HIM certifications at AHIMA, AAPC, and HIMS. I am going to skip my welcome video since Dr. Moreland gave me a wonderful introduction.
Oh, I had to.
So some of the learning objectives, if we were to cover anything, I want to say we're going to explore credentials pertaining to the domains and topics covered so far. Again, they're going to be offered by AHIMA, HIMS, and AAPC. So why get certified? What's the importance of getting certified? So one, we want to increase your earning potential, or you should want to increase your earning potential and your marketability. Being certified helps produce a certain level of job security. We want
One
to help.
second.
Oh,
Right now
okay.
we see our presentation with the slides, like the presenter notes. Could you
Oh,
switch?
well, I don't have any notes, but but
Okay, well, fine.
let's see. Okay, so display settings. Hold on. Okay, here we go. Well, okay, that's better.
No. Oh, here we go. Yep, that's better.
Okay, perfect. All right. So again, if you're interested in getting that promotion, it's a great way to attempt to do that by earning an additional certification. Show that you're willing to invest in yourself and keep up with industry standards. So I'm going to open it up to another poll because one, we learned that 90% or 92% of our audience is made up of experienced professionals, right? So I want to know how many of us are credentialed, right? Credentialed versus non-credentialed. So I'm going to launch that poll. Okay, so the options are going to be that you hold a credential with a HEMA, AAPC, or HIMSS, or you hold a credential or credentials with another accrediting or credentialing body, or you do not hold any credentials, but you're looking to earn one, or you just don't have any, and you don't care to earn one at this time. All right, so let's see how this turns out. Wow, look at that, of course. So far, it's like 97%. Okay, well, nope, 94% of our audience have credentials. That's why you guys showed up, right? To earn those CEUs.
Exactly.
Yeah. Okay, so we have one who don't hold any credentials, but they're looking to earn one. And then we have one who doesn't hold any. So, all right, well, and 95%. So it turns out 95% of our audience is credentialed. So that's wonderful. So I'm going to do this a little bit different since I don't necessarily need to talk about the value of credentials. So I want to hear from the audience. Feel free to let me know what's out there. Tell me how your credential has served you and which way it has served you. So let me jump to my next slide. All right, so when we talk about information governance, the certifications that come to mind for me are your Registered Health Information Administrator, right? So your RHIT. Whoa, where are you going? Don't leave just yet. Okay, so your RHIT information governance represents 24 to 28% of that exam. If you are an RHIA, right, 19% of that exam covers information governance. The CD or CHDA, the Certified Health Data Analyst, is another credential offered by a HEMA. 11 to 15% makes up information governance. So some other credentials that you may explore if you are an information governance professional. ARMA has an information governance professional IGP, and then WAPRO is a certified public records officer. Those are also out there. But during Taryn's presentation, she also made it a point to focus on that compliance piece, right? So then we have some other credentials like the CPMA that she mentioned. AAPC also has a compliance officer position. So I didn't put that in the slide because I really wanted to focus on information governance. So if anybody in our audience who has any of these credentials, can you tell me how your credential or what does information governance look like in terms of in your role? Anybody's open and willing to share? No?
You know, one of the other credentials that I've seen a lot of people in information governance hold is that CHC, and I know that Taryn even has that CHC.
Yep, that's
so
CHC.
that's another
That's a good
credential.
one.
Yeah, that's a good one.
You know, information governance is something that can be just a departmental thing, and it can be an organization wide. And
Right.
I've worked with IT professionals to kind of conduct an in the health as working in compliance. I've collaborated with the IT professionals and the HIM directors to pretty much just do an information governance organization-wide enterprise governance plan. Where's PHI living in, and why is it in this folder and this cabinet and not saved in the patient's electronic record and things like that. So information governance just it can be used in so many ways.
Right.
Yeah.
Thank you for sharing that, Taryn. I appreciate it. That's exactly what I was looking for.
Mhm.
Anybody else want to share? I see there's things going on in the chat.
Oh, a YouTube here.
This is Shalina.
Hi, Shalina.
Hey, Shalina.
Hi. You know, information governance, we've been hearing, this term for so long, but I really feel like, at least at my organization, within the past few years, we've really been more interested in seeing the data. They want to see the data side of everything. And so we have a health informatics team that is our data folks that pull data from all various types of systems that we use into one kind of data visualization tool. So it's an awesome reporting that we never got to see before, and they use Tableau for that.
Mm-hmm.
And but in those processes of pulling data, they are not coders. Our health informatics team is kind of a mix of kind of business office professionals, IT professionals, a little bit of coding knowledge background, but they're really coming to us as health information management professionals to say, okay, what does this data field mean? What, making sure that the entire organization's on the same page for those data definitions of different pieces of data that they're pulling into their reports. So we have become the subject matter experts that our data folks go to understand, what do these codes mean, which ranges of diagnosis codes should we pull in for this type of report, to kind of, so we're bridging that gap kind of between IT and health informatics and our clinical folks to help make that data and those visualizations and charts and graphs and all that good stuff make sense.
Right. Thank you, Shalina.
You're welcome.
All right. So Lakeisha also, she talked a little bit about revenue cycle. So I want to take the time to explore those revenue cycle credentials. There are tons of them. So typically when people think about revenue cycle, they think about billing and coding, right? So I did highlight the coding credentials, starting with the CCA, the CCS, and then the CCSP, which is the physician office. So people typically ask me, and what's the difference between that CCA and that CCS? So CCA is for entry level coders to demonstrate your competency in coding, but you may not necessarily have coding experience. So I encourage people that I work with to get that CCA credential first and then upgrade that credential once you break into the field, once you get some experience, at least a year of coding experience, because in the a couple of years ago, that's what AHIMA advised. They advised that you needed at least a year of coding experience before you were eligible to sit for that CCS certification. So some of the AAPC credentials, you have your CPC, which is your Certified Professional Coder, your Certified Outpatient Coder, which is your COC. We have that CIC, which is that Certified Inpatient Coder. And then they also have that Certified Professional Biller. So I listed here RHIT and RHIA. Some people don't tend to think that those are revenue cycle credentials, but I did want to point out that, oh, where are you going? Hold tight. Okay, so I did want to point out that the RHIT, 16% of that exam covers revenue cycle, okay? So if you're studying for your RHIA, anywhere between 14 and 18% of your exam is going to cover revenue cycle. So many of these credentials do encompass the topics that we're covering today. So, and then HFMA has that CC or CRCR, right? That Certified Revenue Cycle Representative credential. And I've seen that one pop up quite a bit over these past couple years. So anybody or who in our audience have these credentials, can you tell us a little bit how it impacts your day-to-day work? Anybody?
Dr. Sabri, I wanted to just, this is Taryn, and I just wanted to share that there is also a compliance, an AAPC compliance credential called a Certified Professional Compliance Officer.
Right, I mentioned that one, but I did not stick that in there for some reason, but that is a fantastic.
That's okay, that's okay. Yeah.
Does anybody else in our audience hold that credential? No.
I also want to make sure that everyone was taking really good notes because this is going to come in handy here shortly.
I hope so. But I also have, and I'm thinking about giving it to you for the handouts, or if you decide to provide handouts afterward. I have like this little dashboard that tells you, like I saw somebody in our audience is studying for their RHIA, right? So I give you a little bit about the RHIA that basically tells you that you need to have completed a CAHIM accredited program, like a bachelor's degree program, right, in health information management. The exam is $229 for those who are AHIMA members. It's $299 for those that are non-members. And once you are a certified RHIA, you're going to need at least 30 CEUs to maintain that credential. So we can provide that if anybody needs it, but based on our audience, it doesn't seem like, it seems like everybody has a credential.
Okay. Well, it's always good to have just in case. You never know.
Absolutely. Absolutely. Anything to address in the chat?
I was currently studying for the RHIA, so I can use whatever.
Okay. All right. Well, we'll make sure you get it, Bernice. Thank you.
Thank you.
And good luck.
Thank you. I need it.
Yeah.
I saw that Sherika had a question in the chat.
Uh-oh. Ooh. Okay. Oh, so Gabrielle mentioned that she coded with an RHIA. Perfect. I've seen that those with RHIA, RHIT credentials, people will still hire them for coding jobs. So that's important to make note of. Uh-oh, now I think I lost my chat box.
And also, I wanted to point out when I was speaking with Lakeisha, she has her RHIA and her MBA, and she was able to get started in doing a lot of those leadership positions without necessarily having to have that coding credential.
Right.
So it's good to have.
Okay, perfect.
This is Sonia, can I chime in for a quick second?
Of course. Hey, Sonia.
Hi, I'm multitasking here. So my husband is at the dentist needing a root canal, so excuse me, but I've been trying to participate where I can. But I'm probably one of the older RHIAs on here because I was an RRA. I've been doing it since '94, but before there was all of these other credentials, all it was just RRA and ART, and that is now the RHIA and RHIT. So historically, traditionally, the RHIT credential people usually were in your coder positions, and your RHIAs were in your leadership positions, and also in coding positions too, for those that didn't, want to be in leadership. So relatively in the last, I guess, 20 years, the coding certifications have come, to light. But a lot of us old school, like Keisha, we all there was just RHIA or RHIT. There was no AAPC didn't exist. Right. So yeah.
Okay. Well, thank you. Thank you for that little piece of history, right? I love it. So Whitney mentioned, thank you. So the chat is making me feel like I'm a little less alone, right? So there's things going on in the chat. So Whitney said having the RHIT has given her the opportunity to be a float coder and train new coders. Nice. So that's wonderful. Let me see what else we have down here. Okay. Okay. Somebody else, Bia, said that she's an RHIA currently coding. Okay. Oh, we have Sonia. She is a RHIA and a CCS, and she is a program director at Dallas College. Okay. All right. And then I apply inpatient coding and review those submitted by others. Also, as an RHIA, I'm responsible for HIPAA training and for new hires and annually for current employees. Okay, so that's like that privacy role, right? I supervise ROI performance and tracking. Sorry, this box is really small. Okay, here we go. Okay, I also advise IT regarding the newly adopted EMR and keeping PHI safe. Sherika, thank you. I love that. Perfect example. Okay, so yep, Taryn wrote in the chat about the CHC and the CPCO. Thank you. And then Mary said, having an RHIA prepared me so to easily transition from inpatient coder to coding auditor and to an inpatient supervisor. Wow. Okay, that leadership again, right?
Yep.
So Elizabeth decided to say that I have my RHIT and I have done nothing but code since I graduated 20 years ago. Well, good for you. Clearly you love coding, but you know, if you want to move up or you want to transition, you have the opportunity to do so.
You sure do. You sure
Yeah.
do.
You know, I'm just going to speak to that. There is so much value in a coder having 20 years of experience. I mean, I've listened to coders with that much experience, and they're almost like physicians. They know diseases, they know disease processes, they know clinical information, and they are so valuable in that communication role with physicians and professionals.
Yeah, thank you.
Thank
Oh,
you.
so
Well-
Shauna's here. Oh, go ahead.
Yeah.
Okay. Well, hi, Shauna.
Yeah, I love
How are we
that.
doing on time? Because we just got a couple more questions.
We've got about 7 minutes left.
Oh, perfect.
that's
Thank
good.
you, Julia. Okay, so Whitney asked, would we recommend Western governors for BSHIM? So
Yes.
I'm gonna let,
What?
okay.
What? So I guess I didn't give that background, but I got my bachelor's from Western Governors University. It was an amazing program. Absolutely loved that. So yes, absolutely. Yes.
Well, as long as we're plugging, KU Med Center, Rock Chalk Jayhawk, go KU Med Center.
Oh my God. Seriously?
Okay, all right. So what else? Okay, so
So Shauna had a really great question. So
okay.
she said, so for new grads with no coding experience, what's the best resources to purchase for RHIA exam review without getting overwhelmed with certification preparation?
Oh, you know what? So I
this
brought my
is
backpack with me, but I did not. Usually my books are in my backpack. I took them out. But I personally recommend the 9th edition. Well, right now, right? If you're planning to test now or soon within the next 4 to 6 months, I personally recommend AHIMA's RHIA exam prep book, which is currently in the 9th edition, and then the Och and Waters book, which is health information management concepts management and practice. Those are what we tend to use for our RHIA exam prep.
Is that how you say that? I've been saying Oaks this
So well,
whole
somebody
time.
said oats to me and water. We got Dr. Bo on the line. She probably knows.
Somebody needs to make this clear for me because I don't know how to say it. Every time I see it, I think Oaks.
It's Oaks.
Okay.
Okay, thank you.
She
I'm
was
not
one of my
crazy.
teachers, so yep, Oaks and Waters.
Oh, see, oats. Okay, thank you. See?
Thank
You know,
you, because I was saying Oaks, and then when I heard you, I'm like, oh my God, I've
What?
served on
See?
so many
See?
committees
No,
with
so it's
her,
me.
and
Okay.
Saying
I've
it
been
wrong.
saying it wrong. So I think it is Oaks and Waters.
See? Perfect. Thank you.
You know, I got some great advice when I was studying for my RHIA, and I don't know if it's still available, but there was a disc that came with one of the books, and you could go in and take practice questions, and I would take those over and over and over and over until I felt like I understood it. But one of my teachers told me that probably the most difficult thing is you might choose something that sounds like a good book answer, but your experience tells you different.
It's
So
true.
if you're
It's
working in the
true.
health information field. So experience is saying, no, it doesn't, it's not like the book version, and that doesn't always happen that way. And the book version saying, this is how it should happen in a beautiful fantasy world. So just keep your mind wrapped around that you could get snagged up on what your experience and the book says.
Yes, perfect. Thank you so much for that. And what was I going to say? So great tip. There was another. You started off with something that made me think of something else that I wanted to share, but
The book with the disc and the
oh,
question.
yes, thank you, thank you. See, so if you have that AHIMA exam prep book, there are online assessments that will allow you to practice, or there's a test mode where you can time yourself and go through those questions. At the Qualified, we also have Weekend Warrior workshops. Our next workshop is February 26th and 27th. It's an all-day
All
boot
day.
camp. We
Oh my
prep
God.
for 7 hours, at least 7 hours, 7.5 hours, Saturday and on Sunday, covering all the material. So know that if you need an additional resource, we are here for you. Okay. Amitria, she has something. She said she would like to add.
Good morning, everyone. I just wanted to add to Shauna, but Dr. Kendra, you kind of took the half part what I was about to say.
Okay.
But as a newly re-credential RHIA, Shauna, I want to just give you a little bit of advice. Take your time, pace yourself. I studied for 3 months straight in order to take my credential, and I passed in December, but I also met Dr. Kenja through utilizing her resources. She was an excellent help, great in the areas in which I struggled in, one which was in the statistics portion. And as she said, and as it turned out, I barely had any math on my exam, but I just wanted to just give you that wording of advice. And also, since adding my RHIA along with my MBA and my CPC, I have noticed the amount of employers that have reached out to me for higher up positions, and the amount of hits that my resume has been getting just literally over the last 2 months. So for those that don't have the RHIA or are seeking the RHIA, you should see a definite change in how employers reach out to you for higher level positions. So that's all I wanted to add.
Well, thank you.
You know, this is Taryn, and I just want to add something real quick. Whatever credentials you're getting, make sure you are fully aware of the ongoing CEUs that are required in the training to get those credentials. I'm just always baffled when I see someone that's got like 10 or 15 credentials behind their name, and I'm thinking, how do you get anything but education done in order to maintain those, and the cost of those credentials?
They do.
So just be aware.
And for me too, I like to say, you could stick with the same organization if you can. So if you have a coding and you want to get RHIT or RHIA, great. You have them all with the AHIMA, fine. But I think it also gets tricky when you're with multiple organizations, just remembering when you have to renew, and AHIMA requires 30, but AAPC requires 20, so it can get sticky. So, just be careful. But, of course, we would never discourage either way. Just make sure you put those things on your calendar like I do. All right. So I think it's time for us to jump back into the panel, right? Yes. But thank you. Thank you for giving me this time.
Of course, I had to do that. But I wanted to do something a little fun to kind of break the monotony.
Hey, Shakira, your voice is not coming through clear.
Yeah, you started getting a little robot-y.
Yeah. No, you sound like you have a really bad sore throat.
Oh, man.
Oh, okay, that's better. Yeah.
There we go.
I got it?
Yeah.
Okay. So y'all don't like the Barry White or nothing? I can't. Okay. All right. Let me go ahead and, so I'm not the host, so I can't share my screen. Can you give it back to me, please?
Of course, absolutely.
Thank you. Somebody needs to change their They're smoke detector batteries.
I can
Okay.
hear that in the background too.
Okay, let me share. Let me see if I have the right one up. Okay, can you guys see it? Can you see my screen?
Yes.
Okay, so game on. So please go to joinmyquiz.com and I'm going to give you a passcode so that you can take part in this. So again, it is joinmyquiz.com. Once you get there, log on using the code 279417. And I can't toggle between my screen and the comments, so I can't put that code in there. If somebody can put that in there for everyone else.
Okay, what is it again?
279417. And that's at joinmyquiz.com.
Can we play too?
I guess.
Yeah, I wanted to play too.
I guess so.
You asked.
Okay, so I'm going to go ahead and... Uh-oh. Did I start it too soon? Wait a minute.
I don't see anything yet.
Okay. So I have 16 people on right now. Let me see if I can share. It's, you know. Okay, so I have 22 people in, 23. It sounds so dramatic. Like this is
I love it.
I didn't choose the music, guys. I did not choose.
That'd be cool too.
Okay, so we have 28. I think I'll stop at 30 something, 35, because some people may not want to play.
Oh, you're getting great feedback in the chat.
Mm-hmm. Oh, the music is perfect.
Like this is serious, you know, you gotta come with it. Okay, let me see how I can share my screen on this side too. Let's see. Okay, can you see the screen here? Okay, perfect. Okay, so we have 30, so I'll go ahead and end this question. Uh-oh, some people haven't answered the question yet. What y'all waiting on? Go ahead and answer the question.
No, we didn't see it until now.
Oh.
Which
I see it
domain
right
area
away.
would cover compliance issues? What are our
Does it show the
choices?
answers?
No,
There
you
we
gotta
go.
answer it. You gotta answer it on your.
Oh,
on
there we go.
website.
Okay, perfect.
Y'all got it?
Oh,
Yeah, but don't you have to answer it on your website where you went to on your separate page?
I mean, if you go, you log in on your phone or what have you, and it should give you the option to go ahead and answer it that way. You didn't see
Yeah,
that?
it does. Because if I answer, then it'll say waiting for others to answer. But if we
Yes.
answer from here, then
Oh, you got to answer it. You
Yeah,
have to
you
show the
gotta
right
answer.
answer.
you got it. Yeah.
Uh-oh. Okay, let's see. Correct answer was information governance.
Yes.
Okay. Next question. Ooh.
Ooh, I like this one.
Which credential would be most relevant if you wanted to be a coding auditor?
Okay.
Ooh, 8 seconds. No pressure.
And you didn't put
4.
the CPMA on there.
I didn't.
The CPMA?
Well, I couldn't put all of them on there. It's only
I
4
know.
answer choices. Ooh, look at Gabby. Oh.
Uh-oh.
Oh,
Sharon.
don't show the results.
Yes. Okay. So, correct answer. There were multiple answers that you could choose for this. I wanted to switch it up a little bit. So, RHIA and the CPC. Those are great credentials to have for those. Next question.
Jelena said it told her CPC was incorrect.
It told me RHIA was incorrect.
Oh, because she had to answer both at the same time.
Oh, that's why it was an all or nothing. And she
It was yeah, it both of them. And that was a quick timer.
It was.
Time's up.
Ah.
Leaderboard. Sharon, number 1. Sharon is killing it. Sherika's up there. Cynthia, I see you. It will follow on the information governance. So a really quick story about that one. So you know that AHIMA updated their career map, and they have a community health worker as fallen under information governance. So that was a really interesting one. So I'm not surprised that most of us didn't get that right. But good guesses.
I just looked at that too.
Ain't that something?
You just told me to look at that, and
I did.
So
you didn't pay attention. Yeah. Next question.
Privacy officer.
And it might be more than one answer, so remember that.
I want to see what the choices are.
Oh.
Ooh, okay. Oh, you threw the CPCO in there.
I did.
Okay.
Uh-oh. What'd they say? Let's see who's number 1.
Look.
Ooh! RHIT, CPCO, and CHPS.
Yeah.
Those will be useful. All right. Okay, let me see. I think we have one more question left.
Oh, okay. We got a lot of coders in here too.
I know. Own it. Time's up.
All right, let's see.
Leaderboard. All right.
Oh,
okay, I see you, Cynthia.
Gabby kept her lead.
Yeah.
Yeah.
Yeah. Huh.
Okay.
I'll let you choose more than 2.
It only let us select one answer. I was expecting to be able to select 2 answers.
Yeah. Oh, okay. So like CM and PCS.
Yes,
right,
exactly.
Right.
But that's okay because I still won, so I'm excited.
Well, congratulations. Look, Hope's at solid 22nd place. Good for you, Hope. I love it. Right, a hard fought 22nd place. Oh, Shalina.
Oh, cute.
Yes.
You guys will be receiving something special in your email inboxes. So thank you all for your participation. Let me go back to my presentation now.
Oh, look, Cynthia said, what did I win?
Yeah.
A gift card. You won a $25 gift card, ma'am. What did I win? She's so funny. All right, so I'm going to get back into it, and I'm excited about this one. So we are speaking with Aaron Borelli. He is a public health advisor at the U.S. Centers for Disease Control and Prevention. In his current position, Aaron serves as Program Integration Advisor in the Division of Preparedness and Emerging Infections in CDC's National Center for Emerging and Zoonotic Infectious Diseases. Aaron's work provides coordination and integration of partner programs for a large national cooperative agreement focused on prevention and control of emerging infectious diseases, including COVID-19. Aaron has 25 years of experience with the U.S. Let me go back. Where was I at? Oh, yeah. Aaron has 25 years of experience with the U.S. federal government, serving at the CDC in Atlanta, Georgia, and the National Institutes of Health in Bethesda, Maryland. Aaron's experience includes roles in program coordination, health policy analysis, program management, business analysis, and information management with federal programs for infectious diseases, immunization, and environmental health. Everyone, please welcome Mr. Aaron Borelli. And I also wanted to point out that he was a huge inspiration in choosing the topic for this discussion. So he has a very special place in my heart. So I'm excited to hear what he has to talk about today.
Thank you so much, Dr. Moreland. It's great to be with you all today. If you can make me the temporary host, I will share my screen.
Absolutely.
And I love the game. That was really fun to see. And I'm glad that you had a question in there about the community health worker, which I saw that a lot of people mentioned the domain, chose the domain of public health, which public health is not actually a domain within the the AHIMA world. But it certainly is demonstrating the intersection between HIM and public health, which is a lot of what I'm going to talk about. And I'm going to make sure that I can make sure I can pull up my presentation here. It is not allowing me to pick from my my computer. It's asking me to choose from OneDrive, Google Drive, SharePoint. Let me just see what I'm missing. Were the other presenters, were you able to share?
Maybe now. See if you
Okay,
can now. I think I was still hogging the ball.
Okay. That's okay. That's okay. Just it's not letting me select from my computer. It's asking me to pick from
okay, let me see what I can do.
I might have to just have you use the PDF version, which will not be as great, but
okay, let me see.
I don't know why it's not. I've never had this experience with Zoom before, so I'm a little bit confused.
Did you
It's
go
okay.
to the advanced tab or the file? And it's not there?
Yeah. It tells me slides as virtual background, portion of screen, computer audio, video, and content from second camera.
Okay.
And when I do files, it's everywhere but my actual computer.
Oh.
It's Google Drive, it's Box, it's OneDrive, it's SharePoint, Dropbox.
Hey,
so
it's okay. It's okay. That
yeah, we might have to just use. Do you have the
Of course
PDF
I do.
of the slides? We can just, and I'll tell you when to advance. I apologize for that.
Oh, that's okay. That happens. Give me 1 second. Let me go ahead and get this up here. Share my screen. Oh, could you mark me as the host?
Let's see. Yeah.
Okay. How about that?
Yes, perfect.
Perfect.
Thank you so much.
You're welcome.
All right, awesome. Well, hello again, everybody. It's great to be with you all. And thank you for the introduction, Dr. Moreland. So today I have a couple goals with this presentation. I want to help you all learn a little bit more about public health data and how it's used. I want you to see some of the important connections between HIM and public health. And I'm hoping that you have an aha moment about something that you learned today. I'm not going to go in a whole lot about data analytics as far as conducting data analytics, I want this to be a little bit more about understanding the data and how it's used. And like I said, some of those connections with COVID-19, public health, and HIM. So you can go to the next slide. This is my disclaimer. I do work for the federal government. I'm just letting you know that this presentation is my personal views and opinion. I am not officially representing the government in any way during this presentation. Next slide. So I wanted to start by looking kind of at the big picture of HIM and public health data so that we all kind of understand where we're starting from here with how we use public health data. And one of the main uses is to detect, investigate, and track cases. And a lot of times we refer to this as surveillance. And this kind of forms the basis for epidemiology and public health. And so we use that also for estimating cases, deaths, and testing, which has been critically important if you've been following anything related to COVID and the pandemic. We also use it for health resource utilization and access. We use it to determine things like vaccination status, rates, administration effectiveness, looking at subpopulations or special groups. So these are areas like health equity, looking at vulnerable populations, looking at different types of healthcare settings. And then lastly, measurement. How did we do? How are we doing now? And where do we want to go? Next slide, please. So I'm going to share a couple examples of how public health data is used related to COVID. And the first one is the CDC COVID data tracker. A lot of you may have seen this if you followed anything with the spread of COVID in the United States. And you can see this is through CDC's website. And this is a great visualization example for public health data. And you can use this for things like forecasting, for looking at vaccinations in the US, for looking at pandemic vulnerability index. There are also state level data trackers that you can look at. So if you want to look just at a specific state, and many states host these on their websites as well. And you can kind of drill down, as you can see here, to the county level. You can go to the next slide. The next one is COVIDNet. And COVIDNet is a surveillance system that collects data on lab-confirmed COVID-associated hospitalizations among children and adults, and it uses a network of approximately 250 acute care hospitals across 14 states. Again, this is available on CDC's website if you ever want to take a look at this and view some of the data from this system. Next slide. And then COVID vaccine data. And obviously, vaccines have been critically important during the COVID-19 pandemic. We're extremely lucky that we have a COVID vaccine and that happened quickly. And we have millions and millions of people in the United States who have been vaccinated, luckily. And so reporting on that data and being able to use it in meaningful ways and make decisions about it is reliant on the data that's fed into this overall system. There is not a national vaccine registry that collects all this information. It is all done at states and jurisdictions. So all of that type of data is reported up to the national level, but it is all from a system of state systems. So CDC, together with other federal agencies, vaccine providers, state and local public health departments, et cetera, you're using this data to inform decision-making regarding COVID-19 vaccination. And as we know, this has been critically important during the pandemic. Next slide, please. All right, so some COVID healthcare setting data that's available. And again, this is based on the CDC website, and you can see the link there at the bottom where they have compiled a lot of these different types of data into different visualizations and data sets that can be used depending on what your needs are. And hopefully you can see from this list that this is very healthcare oriented. So there's kind of a distinction between private or medical care, and then public health care. But you can see here an obvious intersection, because we're talking about hospital type data, we're talking about hospitalization rates, nursing home information, healthcare personnel, emergency department visits, knowing better about disease severity, et cetera. So you can certainly see here, excuse me, how a lot of this data is reliant on that clinical care setting information to help feed how we look at something such as COVID in a public health lens. Next slide. So on this slide, I'm showing, just so that you all can kind of be familiar with some of the different data sources that are related to COVID healthcare settings. And you may or may not be familiar with some of these systems. We talked a little bit about COVIDnet, but you can see here there are lots of other surveillance systems that are used. And if you wanted to learn more about these, you could click on these links on the CDC website, and you could learn what types of data elements are included in this, and how the data are collected, and a little bit about how the data might be used. So this is just to kind of give you an overall picture of some of the surveillance systems that tie in from care that's delivered, and how it might be used for public health purposes. Next slide. And one of the ones I wanted to go into, just for a little bit of context here, because this is about HIM and looking at COVID data, is the COVID emergency department visit data. And you'll see in the description here, you should see some of our HIM friends. If you can do the next slide. Aha, electronic patient encounter data. And they're looking at syndromes based on chief complaint and ICD codes. Haha. So there is a connection right there. And so you can see there are certainly, this data that is being compiled and gathered within the HIM world is making it over into the public health realm and used for some of these other purposes. Next slide. Next example I wanted to share is COVID vaccination, which, like I said, has been critically important during the COVID pandemic. There's a lot that goes into COVID vaccination data, and the website provides a lot of detail about what's used. And you can see that there's a lot of different sources that help make up the visualizations that are shown to whenever we're looking at the overall picture of COVID vaccination across the country. If you go to the next slide, there's some other information in here, just looking at something like total doses administered and what's involved in that. And you can see from this box here that there's lots of sources where people are getting vaccinations. So all of those facilities and places need to be accounted for. And so there needs to be accurate reporting of these vaccinations to other systems, so that we're making sure we account for everybody. Because with COVID, we've seen an explosion of where people get their vaccines. It's already had moved into a lot of other types of settings where people get vaccines prior to COVID, because of things like flu vaccine or maybe shingles vaccine that have made it into like retail pharmacies. But COVID has made it where it's even more where people could get their vaccine. So all of this needs to help feed into a system for accountability. If you go to the next slide. We can start to look at some of the complications of COVID vaccination data. And we recognize that there is some missing data here. And you can see that even on the website, we acknowledge that there is some demographic data that might be missing. There's some other information that is influenced by the variability of how vaccinations are reported. So I'm going to just highlight these three bullets here. If you go to the next slide, the first one is the inconsistent collection of race and ethnicity information. And you can go to the next one. differences in jurisdictional electronic data programs, like we were talking about. This is all based on state systems, so depending on how they do them, and the next one's fine. Yep. And then jurisdictional policies or laws that might not allow certain demographic data to be reported. So these are some challenges in collecting this type of data, and in something as complicated as millions and millions of vaccinations at all of these different points and all of these different types of facilities. So this is something that we're always looking at ways to improve this, but it's certainly we acknowledge that this is a challenge. Next slide. All right, so the next area I wanted to mention, since we're talking about data analytics, is the area of modeling. And this is a fairly common term within the public health world. And what we mean by modeling is using data from different sources to help us improve our awareness of a situation, assessing critical needs, and informing our decisions using evidence. And this is something that has become extremely important because of the COVID pandemic, but we were using this prior to COVID as well. We use this normally in the public health world. Often it's used for things such as flu, especially either a seasonal flu or if there is something like H1N1. Because of the importance that modeling plays and recognizing that in trying to increase our ability for preparedness and response to infectious diseases, the CDC actually is creating a new center for forecasting and outbreak analytics. So this is something that is actively being stood up right now. This did not exist before. This was something that came out of what happened with our experience in the COVID pandemic. So it's very exciting that there'll be a center focused on this. Prior to this, a lot of these activities were done in certain components or parts of the organization at CDC or the federal government. And we're trying to have a more concerted effort of organizing some of those efforts. And so we'll use that to help advance the use of forecasting and outbreak analytics and helping to bring together public health data, disease modelers, emergency responders, and communications. And so obviously these efforts need people who can do modeling and who are analytics practitioners. Next slide, please. So the next area I wanted to cover is data modernization and health information systems. And data modernization is a federal nationwide initiative to improve and strengthen data systems to state and local officials so that they can more accurately detect and contain infectious diseases. And CDC has been very involved in helping to lead this effort across various programs and projects. You might also hear this referred to as DMI, which is Data Modernization Initiative. As part of this, some of the things that are included in here are things like electronic case reporting, e-case management, surveillance, and these are also tied to what you might have heard about in COVID-19 terms have been like case investigation and contact tracing. And so COVID has pushed a lot of these processes and systems to the limit. And they've required quick changes, additional staffing and resources, and a new reliance on data and technology, and then variation among the states on how to do this. So part of this effort is to try to bring together some common standards and guidelines among this, and to provide resources and technical assistance to improve the infrastructure and processes around these areas. Also related to this are immunization information systems, which you might be familiar with, are also referred to as immunization registries or vaccine registries. And we have been working on these areas for many years, but of course, the importance of this has come even more to the surface during COVID because of making sure that as many people are vaccinated as possible and being able to accurately track that information. So again, enable to best do this and identify things like gaps in vaccination coverage, and making sure that people are getting their vaccines when they need them. We need these type of systems, and we also need things like interoperability with electronic health records, which is a challenge, and we'll talk a little bit more later. And then the changing guidance and data collection. This includes definitions of what is a COVID case, what is a breakthrough infection, what constitutes being fully vaccinated, what is a close contact. And so lots of important items to consider there, and things like matching hospital admissions or patient case data with immunization records. So if somebody comes into your healthcare facility, how do you verify that they received their immunization, and what's the system that's used to cross-check that? So those are really important things to consider. And then also things like how are people being listed in their diagnosis for COVID, which was talked about in some of the earlier presentations. So next slide. So we recognize there are some areas for improvement in public health data. I listed 5 that I think are some of the biggest ones. One is struggling US data systems. It is a patchwork of systems across all of the different states. So areas of public health that do epidemiology or laboratory work, et cetera, have a need for some modernization. And there's certainly a reliance on the state system, because although they might get funding from the federal government to do a lot of these things, and they might get funding from their state, they still have their own way about doing all of these. The public health system data infrastructure, healthcare facilities often don't talk with each other or with the public health systems. COVID has again kind of highlighted the importance of some of this, and some of these connections are now being made more than what they were before. Finding, hiring, and keeping staff. This is especially true for areas like health informatics, bioinformatics, and certain specialty areas. The need for health equity data. We talked a little about health equity at the very beginning of this presentation. We need consistent, standardized information and that demographic type information and other characteristics to be able to address vulnerable populations. And then funding. There's lots of different sources for fundings. They can be variable. Sometimes they come in waves, because when there's an urgent issue, the money flows. When there's not an urgent issue, it might stall. So trying to make that process a little more strategic and sustainable is certainly very helpful here. Next slide. So some ties to health information management and public health. The key thing obviously is EHRs and EMRs and any information that would come out of a patient encounter. And so this is obviously key for supporting public health data. Like we mentioned, there are lots of surveillance systems that depend on health information. One that you all might be familiar with are registries, and you might be more familiar with things like a cancer registry, but there are other registries that are used in public health. So environmental, ALS, there's actually one for the World Trade Center after 9/11. And then, like we mentioned, immunization information systems or vaccine registries, which have been around for many, many years. We have a very large program at the CDC that helps to work with all of the states across the United States to support their immunization registries through funding and technical assistance. We have been encouraging things like meaningful use and interoperability with electronic health records. Vaccine codes fit into this. Also, of course, during the pandemic, COVID vaccine codes. So a lot of important ties there with COVID and HIM because of, again, feeding up into that larger system of being able to use data about vaccines that are administered and reporting that at a national level and using those visualizations is incredibly dependent on this being reported from where it's administered the whole way up into these national systems. Next slide. And continuing on this EHR use in public health, one other area that I'd like you to be aware of is the National Center for Health Statistics. If you're not already familiar with this center, it is part of the CDC. It is actually one of the centers that is not located in Atlanta. It's based in Maryland. And they do a lot around vital records and statistics. They are involved in diagnosis codes, and they actually conducted a national electronic health records survey back in 2019, and I have the link here. And they found some information about the percent of office-based physicians that are using an EMR or an HR system, and you can see the results there. So they do some work related to HR. So it's just a nice tie-in to HIM and public health. And then the importance of accurate medical documentation. So again, just showing that how important it is for documenting something like a COVID case and whether this person was admitted to the hospital because of COVID or with COVID. Some of those things are, can make a very important distinction, and shows how much we rely on accurate health information, because there's lots of implications for how patients are diagnosed and reported for their COVID cases. Next slide. And then I thought this was an interesting coding intersection for you all. When we're talking about vaccine data and vaccine codes, in the world of immunization information systems, we have what are called CVX codes, and these indicate the product that was used in a vaccination. So this is used for HL7 data transmission. And if you go to the next slide, you'll see some more friends. What do we have here? CPT codes linked to CVX codes. This table that's provided here is just one part of it. There's lots more if you look at the website. But again, you can see the intersection of data here from HIM with public health and how this is used for lots of other purposes. Next slide. And then this is just a quick example of HIM data and technology kind of working together. This was a recent article in an HIMA Smart Brief, and they talked about this app in the state of Illinois where people could use this portal to look at their immunization records and help people, create an account for themselves, et cetera. So it was just another example of how this HIM data is being used in these new ways. And, states are kind of having to create new platforms for people. And we have been encouraging some of this for years in public health, and now it's come to the forefront of where people want this information. They need this now. Things like vaccination records are even more important than they ever were. So you're seeing some innovative advances in what people are creating for allowing people to access their information. Next slide. And then I included in here a few examples of articles that were published within the last year or so that looked at the intersection of COVID and electronic health records. And I have 3 of them here. And so you can take a look at these later if you want to. And they all basically are saying that, they're highlighting the importance of EHRs during the COVID pandemic, how EHRs can contribute to help public health response as well as patient care, but they must be interoperable, and we need to understand how the data are generated and not just how they're extracted. So just some interesting articles to keep in mind, and that there are people out there in more of the public health world who are looking into these areas, and as you can see, publishing articles about the importance of EHRs in the COVID pandemic. Next slide. So this this was just to kind of highlight some of the overall obstacles and roadblocks in the area of using data in public health world. And you know, like we said, there's this patchwork of public health data and sources. The area of data modernization, we need improved health information systems, we need more integration. These are areas where lots of people across the country are working.
Did I lose him? Is he still there?
Aaron, we can't hear you anymore.
Sorry about that. Can you hear me now?
Oh, okay.
Yes. Yes.
Sorry about that. Yep. Yep. So prioritization and where to put our efforts. You know, do we focus on all case investigation and contact tracing, or do we prioritize that? How much effort do we put on actual, you know, vaccinations? At what point, you know, or are we satisfied with how many people, you know, are either complying with our guidelines or not? And how much do you work on trying to convince people of certain things, trying to, you know, address things like vaccine hesitancy, et cetera. Future funding is, of course, an obstacle, and something that right now funding has been, there's been lots of funding that has gone out to a lot of states, and there's a lot of support in order to address the COVID pandemic. But at some point, will that stop? And when the next emergency or something else happens, does the shift in priority become, you know, another area? Addressing misinformation and disinformation has been a challenge. And then, of course, fatigue with the public and private health system. And a lot of you probably know that from your experience. You know, we recognize that, you know, we're now going into basically the third year of dealing with the COVID pandemic, and people are certainly getting tired. They want to move on. And I think a lot of us want to return to some sort of pre-COVID normalcy. When that will happen, we don't know, but we're hoping that, you know, in 2022, that things start to calm down a little bit, and we can learn to live with COVID better and manage things. So next slide. All right, and this is actually my last slide. So thinking about some of those obstacles and roadblocks, I wanted to provide some suggestions on things that help in the area of public health data and HIM. And the first is staying informed of public health developments and policy in the country as a whole, but also in your state. Understanding your role in the bigger picture, including the importance of current and accurate HIM data. And I think that for a lot of HIM professionals, because a lot of the work that you do, it's tends to be more detail oriented and more kind of task oriented, or where you're looking at one patient at a time and one record at a time. And it can sometimes be difficult to see that bigger picture. Hopefully through my presentation, you understand better how this data is being used beyond maybe what the traditional uses are that you're aware of in your own facility. Staying current on education and training. We heard a little bit about that today as well, and the importance of that. There's lots of different types of education and training opportunities out there. Take advantage of them. Not all of them will be things that are maybe directly HIM related, but they might help you with better understanding how data is used, or how maybe you can expand your role, especially if you want to maybe move out to something more in either doing like data analytics work or something in public health data. Ask questions and reach out to trusted sources. Find people in your organization who know about some of these processes or how data is used. Make sure that you are not relying on you know, people who might not be providing the best information about things. So there's a lot of information out there about COVID and public health, and there's so much online now. And make sure that if you're going to get information about public health information, that you're using trusted sources. That's very important. And then to get and stay connected with professional networks, especially LinkedIn. I think LinkedIn is awesome. I want you all to make sure that you're connecting with your peers and you're learning from each other, you're asking questions of each other. So use those networks. And then lastly, to support each other, and especially support those who are in healthcare and public health and our essential staff and workers, because we are all in this together. Next slide, please. All right, and this is just some more information if you'd like to learn a bit more about some good sources for COVID data. You can see the data tracker, some general COVID information from CDC. There's a great website called healthdata.gov, which has a lot of compiled information across the nation. And then the Johns Hopkins COVID tracker is also a really great site and has been at the forefront of doing visualizations and data analytics on COVID since the start of the pandemic. And that actually was my last information slide, sorry. Next slide.
Oh.
Yeah. Next one, yep.
Oh,
yep. So thank you all, and I'm happy to take any questions.
Thank you so much. That was such a robust presentation. Thank you so much for sharing that with us. One of the questions that I wanted to ask you was in regards to, I know that as HIM professionals, we may not know much about what's going on in public health, but on the flip side of that, do you think, or does a public health realm understand the importance of HIM professionals in regards to collecting that data so they can use?
Yeah, I think they do, but I think that there's probably a lack of awareness among a lot of public health professionals about the HIM world and the role that they really play and how much information and knowledge they actually either have or are responsible for. From my experience, I think that most people in public health, especially at the national level, but probably also some at the state level, although they understand the basics about some of this, they don't know to the extent that HIM professionals do, and they don't know as much about the credentials and that, the specializations, and most of them are not going to be familiar with the credentials that HIM professionals have. And that's why it's important that people who have those credentials, that they explain them, that when they display them, that they be prepared if somebody asks them a question about it. And that there be, more interaction and communication between HIM professionals and public health professionals, because a lot of that connection might not really be there. Although there's this reliance on the HIM data, they often don't know a whole lot about what went into collecting it and managing it. And I know that in my experience in many years in federal public health world, I've seen very, very few people who have the credentials that were talked about today. I mean, I'm one of the very few people with an RHIA that I've interacted with in my many years, especially at the CDC. When I was with the NIH, I was in a health information management department. So a lot of us were either an RHIA or an RHIT. But since being at the CDC, it's not like that. And a lot of the people we interact with at the state level are also, they're doing a different type of role in public health. So they're usually not credentialed from an HIM perspective. So yeah, I think there's probably a gap there.
Yeah, and so another question that I have for you. So I know that you went back and you got your MPH, your Master's in Public Health, but for those RHIA professionals that just have their RHIA, do you think that it's required for them to have that additional education to move into a role similar to what you're doing, or do you think that having that RHIA would be enough?
No, I don't think it's required. There's a lot you can do in public health with whatever degree you come with and whatever other experience and credentials that you happen to have. I think that It certainly helps, if you want to move into the public health world, it helps to have some type of education that's at least related to public health or health informatics or health science or something that touches on one of those topics. So it just kind of depends, I think, on what type of role that you want. A lot of people come to public health from somewhere else. We have a lot of people who didn't start out in public health and kind of made their way into it. And we welcome everybody, of course. And there's a lot that you learn on the job. There's really, a lot to be said for being adaptable, being a quick learner, and being willing to learn new things. Some of those basics are certainly useful, and it's helpful to have some type of a degree related to public health, but you can make your way into a public health type job without an actual public health degree. And then you can always decide later if you think you want to go back and get it.
Okay. All right. Any other questions from our audience?
Just getting some beautiful praise on the event and the expertise of our speakers today. So thank you all.
Great.
Erin, this is Taryn, and I did want to ask you, just listening to the CDC information, and I'm sure you might have even seen some of the TikTok videos about, the wear a mask, don't wear a mask, double a mask, and then, different things like that. What do you recommend as a response with the rapid changes? Because I get questions all the time, about what the current CDC guidance is. And I always tend to want to kind of back that up with understanding that what's happening in the background as you're trying to manage those changes and that information. So can you share just a little bit about how this pandemic has changed and caused the CDC to find the pathway, say, for instance, for the next pandemic or the next time that we have to face something like this?
Yeah, thanks for that, Taryn. That's a very complicated question. I could probably go on for a long time about that, but I won't, I promise. A couple important things there. One is I think that for people to understand that with something like a pandemic of a new infectious disease, it is essential that public health adapt as needed and base our recommendations on whatever the latest evidence and science are. And things do change, and we're learning about this as we go. This was a new infectious disease. When you have something that is new, such as this, there are only so many types of ways that you can either prevent it, prevent the spread and treat it. And so because this was something where there was not a vaccine already, there was no type of other countermeasures, really, there was no type of clinical treatment at the time, we had to learn on the fly. And we had to, at the beginning, really rely on things that were like the basic public health prevention measures, things like, social distancing, physical distancing, people quarantining in isolation, masks, et cetera, avoiding, trying to avoid so much contact with each other. Those are basic public health measures that you have to implement when you have something that is new and when there's nothing really else that you can do. And as you learn more about how this spreads, where it's at, what parts of the country are being affected as it's moving around the globe, all of that is constantly changing. And as we, luckily we quickly developed a vaccine, and so we had that available. But like the use of masks was something that we really hadn't had to focus on before. So we've had to constantly adapt and figure out how much is this helping, how do we recommend this to people? People are not used to having to wear masks in their daily life. So I think it's just people being willing to change with us as the information changes, and understanding that this is a virus that spreads very easily and very quickly. And there are serious, implications to its spread. And in order to prevent that, there are things that we have to do that we have not had to do before. And the only way that we're going to move past it and get out of it is if people all cooperate and participate and be willing to adhere to guidelines. We recognize that they do change, and we don't take any of that lightly. I mean, if we make a change to something and we have to communicate it to the population or the country, it's not just on the fly, or it's not just that we feel like, oh, let's just try this and see how it works. It's based on, we're looking at what's working, what's not working, recommending that people look at the amount of spread in their area, and trying to determine what your risk is, and recognizing that there is a lot of personal responsibility for people. You have to take the information that we're providing and that you might be hearing from other sources, and try to make the best decision for yourself and what you think your risk is, and the willing of risk that you're willing to take. And these are things that people aren't usually used to doing, and don't want to do. They're getting tired of them. We understand that. But all of it is based on evidence and science. We're trying to put out information about studies that have been conducted on mask use and vaccines, et cetera, and make that available to people. But the bottom line is that the average American is not going to want to look in detail at the science. A lot of, they're not going to read, all the details. They want the top line information. What do you need me to do? Maybe they might ask why, but they want a 1-minute answer. They don't want the real, long science explanations.
I think most of us that work in the health information industry are envisioning the CDC has been drinking from a fire hose now for the last 2.5 years. And I can just see some sort of manual and work plan for future pandemics or future instances like this, just redlined, redlined massively. It's like, okay.
Yeah. Well, yeah, absolutely. And, we're learning from this. And, one of the things, like I mentioned, was, creating that new Center for Outbreak Analytics and Forecasting, which would hopefully help. Learning about communication messaging, learning that people get information in lots of different ways now. People want information certain ways that maybe we weren't aware of before, that there's so many other people that we're competing with to provide our information. And we really need to try to get out there first and be credible and accurate right from the start, which we try to do. But when you have so many other sources that are coming at people and telling them other things, we recognize that's a challenge. And the other thing is, when we did pandemic preparedness prior to COVID, it was very flu-based. It was more for a flu virus. We thought it would be something like an H1N1 that would start somewhere in the world and might possibly become a worldwide pandemic. What we ended up happening was a coronavirus, which is different from flu. It's totally different type of virus. So we had to adapt, and whatever plans we made for flu, some of it could be used, but some of it couldn't. And I think one of the big lessons learned was thinking that we could tell everybody to go on lockdown and do all of these restrictions. Number one, it's way more complicated than we thought it would be. And number two, you have to be prepared that this could go for much longer than we ever thought it would. When we did planning in the past, we thought, well, it might be for a few days or a short amount of time, and people would, be able to be restricted, and, then things would ease up and whatever. And we would start using like a flu vaccine, and we could hopefully use some flu that was in a stockpile. And, we never thought it would go on for years, or you would, be restricting people and needing this widespread use of masks and travel implications, et cetera, and business implications. Like, that really was not considered as much in the planning. And I think that's a really big lesson that has been learned here that will influence how we address this in the future.
Thank you so much. good
So,
information.
yeah, and I had another question for you. So during the presentation, you spoke mostly about the COVID-19 vaccines, but is this also true for other vaccines?
Yeah, yeah. I did focus very much on COVID in this, but I hope that people will take away that this applies to other vaccines as well. I mean, there's not the same amount of usually interest, and there might not be as much widespread use of some of the data or the visualizations that are done for other vaccines. Although, I mean, it certainly is if needed, or it might be more state specific or local specific to how you use that data. But a lot of this does apply to other vaccines as well. All the other vaccines are included in an immunization registry. Or an immunization information system. There are people who are looking at that data as well. So it is certainly important. So yeah, there's a lot of similarities between what's used for COVID vaccine data and other vaccine data. It's just not highlighted on the news every day.
Right. I wanted to give someone else a chance to answer or ask some questions because I could go on all day. So anybody else before I ask one final question? Okay. All right. So when you talk about the asking questions and finding these trusted resources, could you please just give us a couple of examples of these trusted resources so I can pass them on to people that I know that need it?
Right, right. And I did mention a little bit, I think, in my presentation about that, but yeah, making sure that you're finding people in either your organization or in your state or local area that are working with this type of data. And so you might need to reach out to others in your organization and find out, where else does this data get reported? And how does that happen? Who's the person or the group in our organization who is working with this data? And when you find that person, contact them and say, I'm interested in this. Can I meet with you? Can we talk a little bit? I just want to better understand how you use this data and where you report it to. And also if you can't find that in your organization, or it's not as relevant to your individual situation, reaching out on places like LinkedIn or your other professional networks and looking for people who work with this type of data and just asking them questions, asking to set up a meeting with them, ask if you can do like a Zoom coffee and chat or something and talk with them about how they use this information, and ask them, do you work with HIM professionals? Do you work with HIM data? How does it get shared? What systems do you use? So that's certainly somewhere you can start. And you can, when you see things on something like LinkedIn where people are posting about this, don't be afraid to ask a question on that post. If you don't want to do it in that form, you can always contact them privately. But sometimes by posting in those situations on like social media, then it sparks these other conversations and other people who would chime in. And number one, you'll get answers to it, but then number two, you might get some other leads as well of other people who are doing this type of work that you could start to develop either a relationship with, or some type of connection to learn more about what they're doing.
Perfect. Thank you so much. You have been amazing. Oh, my goodness.
Thank you.
Thank you again for even just coming up with this idea, being able to present all the information that you have, and you've made it to where everyone can understand. So thank you for doing
Good.
that.
My pleasure.
So we will go ahead and move forward. Unfortunately, our final panelist, Ashley, had to drop off due to time constraints because we did go over a little bit. We've been having too much fun. I'm sorry. But we'll see. I think I'm going to be able to get some recordings from her so she can still present that information. I'll send it out to you guys' email because there's going to be great information in there as well. So do not fret. You will be able to get access to that information if that area of informatics and privacy and security is something that you're interested in. So what I'm going to do now is I'm going to send it back to Dr. Sabri. She's going to talk about some of the certifications that would still be relevant to either getting into data analytics or informatics. So it'll be interesting to you. Make sure that you take notes because we're going to have another game coming up shortly. Do I need to make you the host again?
Yes, ma'am.
All right, there we go.
Thank you.
You're welcome.
All right. So where did we leave off? And I'm sorry to hear that our panelists had to run. I was really looking forward to that last session.
We've been having too much fun.
I know, but next time we'll do a better job at keeping track.
Yeah.
Okay, which screen do you guys see?
We see the whole presentation with the things on the side too.
Okay, perfect. Okay, that's fine. Okay. So we are, I don't know where my mind is. I don't, look, you should be at the bottom, right? It acts like it doesn't want to work, but that's okay. See, now it's sharing the other screen. Okay. There we go, right? Better?
Yep.
All right, so we left off covering revenue cycle and talking about revenue cycle. So I want to jump into the data analytics and informatics. I didn't realize Ashley was going to encompass a little bit of privacy too. So for the privacy certification, AHIMA has the Certified Professional Privacy Officer, I think the CPHS. Well,
CHPS.
CHPS. There we go. See, there we go. Thank you. So that one's out there, and okay, here, this should be a little bit easier. My arrows act like it didn't want to show up for me. Okay, here we go. All right, so when we talk about data analytics, immediately what comes to mind for me is AHIMA's Certified Health Data Analyst, the CHDA credential, in addition to the RHITs and the RHIAs. So for RHIT, data analytics represents 14 to 18% of the exam. And for RHIA, it represents almost 25%, so 24% of the exam. Okay, so I also highlighted a couple different public health certifications for those that may be interested. HIMSS just came out with a new certification. It's the Certified Professional in Digital Health Transformation Strategy. That one launched, I want to say earlier this year, if I'm not mistaken. So that's the CPDHTS, if you're interested in that. The NBPHE has the certification in public health. So that's CPH. So I know Erin mentioned that you don't necessarily have to pursue a master's degree, but if you want to instead throw that credential on there, feel free to do so. Okay, and then also we have NCHEC, who has the Certified Health Education Specialist. Okay, and that covers a lot of that data analytics. So does anybody have any question about these certifications, or outside of the RHIT, RHIA, do we have any CHDAs with us, or anyone who holds any of those other certifications? Okay. No? All right. So whenever I think of data analytics, immediately informatics comes to mind. So I did break these slides out separately. Just in case. So I'll jump over there. So when I think of informatics, some of you may know that AHIMA discontinued the CPHI in addition to those CHTS certifications. So right now, the leading certification body is HIMSS in the informatics space. So you have the Certified Professional in Healthcare Information and Management Systems, the CP HIMSS. Okay, and the CP HIMSS is for those who have at least a bachelor's degree. And then you have the CA HIMSS. The CA HIMSS is a lower level credential. It's the Certified Associate in Healthcare Information and Management Systems. So you do not have to have a bachelor's degree. As long as you have some experience in informatics, project management, you are eligible to sit for that particular credential. Okay. And then AHIMA, right? So the RHIT, RHIA, as I mentioned before, each has specific areas in data analytics and informatics. Questions, comments there?
I'm taking myself off of mute. I was going to type it in the chat, but I'm using my iPad. So, oh, I'm sorry. Someone else asked the question too. Alexis. I'll let her go first. She's in the chat.
Oh, well, thank you, Gabby. All right, okay, so I'm coming from an HIM background, but I want to go into data analytics. Should I go for the CHDA instead of the RHIA? That's a fantastic question. And unfortunately, I can't just give you an answer. So sorry, because we need to connect, right? We need to see what other experiences you have. We need to look at some of those transferable skills and to better understand what your situation is. So if you would like to connect after that with myself or Dr. Moreland, we will be happy to answer that question for you. And it depends too if you have, right, that's a fantastic question. If you have experience in data analytics or not, that would also make a difference. But I think those are both great choices. So I don't think it matters which way you go. Okay. All right, Gabby.
Okay. My question is geared towards the HIM certification. So I have my RHIA, and I have found myself in more on the IT side of HIM. So my last job was a implementation specialist for a software vendor, and now I'm working for an organization on their clinical software application side. So can you just speak a little about the differences between the professional and associate for the HIM certifications? Because I've read it and it seems like they want you to have years of experience to do the CP HIMs as opposed to the CA HIMs. So can you speak a little bit more about the requirements for those?
Well, they actually, yes. So hold on, and I have it pulled up. I can share it with you. Let's see how quickly I can do this. And I wonder, so when you say, how many years of experience do you have? Because it sounds to me, just based on what you said, it sounds like you meet the criteria for CP HIMs.
So I have, I guess total, it's going on, I guess maybe 3 to 4 years, somewhere between 3 and 4 years. Yeah. The IT part of it, I've been in HIM for 12 years.
Okay. All right. So can you guys see my screen? No, you can't. Okay, I can see my screen. All right. So hold on. So all right, so for the CP HIMs, right? So I said the requirements for CA HIMs is just the high school diploma, okay? So the requirements for CP HIMs, okay, you have to hold a bachelor's degree, right? Okay, and at least 5 years. So you're close.
Okay, thank you. So I guess
You're welcome.
I'll sit tight and
yes,
yes, in the near future.
Right. And you can always take the approach of, like we say for CCA and CCS, right? Get the lower level credential and then upgrade to that higher level credential. But you're so close. I think you should just kind of hold out. If you have a graduate degree, it requires you to only have 3 years of experience.
Okay.
But another criteria is you need to have at least 10 years experience in information management or in HIM, so you do. And it says 8 of those must be in healthcare. So you meet that criteria too. So if you want to just hang tight for another year, you will be all set.
Yeah, I'll just hang tight.
Okay.
Thank you so much for the information.
No problem. And something else that's worthy of mentioning is, so the CA HIMs If you are a member, it's going to cost you $199. If you're not a member, it's going to cost you $259. The CP hymns, on the other hand, if you are a member, it'll cost you $399. Otherwise, it'll cost you $549.
Ooh,
Oh my
Lord have
gosh.
mercy.
Yes.
Also,
yes.
does the Qualify offer prep classes on those certifications?
We actually do, yes.
Oh, awesome.
Yes. And something else that I thought was a little out of the norm, not necessarily out of the norm, but hymns require you to earn 45 CEUs. So that's a lot. Any other questions?
Mary has asked a great question in the chat. Would you like me to read it to you?
Yes, please. Thank you.
So Mary shares, I have my RHIA and work as an inpatient coding supervisor for a large healthcare system in Dallas-Fort Worth. I'm looking to add certifications. From the healthcare system perspective, what's a good place to start to add certifications to build on my coding background, but also branch into related areas? CDIP, CHDA, compliance certification, other, they all look fascinating.
Yes, yes, yes. And that's another one where I feel like I can't answer, right? Yep. So we would need to see those of you, first of all, let me make sure I'm going to put, or Julia, if you have my email, can you please put it in the chat? Please email me, Mary, and then I can't remember who was the other person who asked that question, and I said we would have to see it. Please email me your resumes and we can take a look at it and we can determine the best certification for you. Right, because you mentioned, okay, you have a coding background, but do you see yourself in CDI? You know, that's a great progression. We see it all the time. So you might be interested in earning that CDIP. But if you say, well, I want to be an auditor or coding auditor and you want that certification, you might be more interested in a CPMA or the CHDA or, you know, something like that. So we just have to see, and you might want to follow back up too with Dr. Moreland, right? To really find or create that alignment to figure out where you're trying to go, for sure.
Great questions. I love the participation. Love it.
Me too. Me too.
What else we got?
Do we have any other questions? Good. I'm glad Bernice, she said she doesn't regret joining. It was worthy.
Yay.
Yay.
Good. Okay, so I'm going to go ahead and get into our last quiz for today. $25 Amazon gift card. So put your hats on. I hope you guys took some really good notes. Yes. Let's see what we got. Can you switch the host back to me?
Yes, ma'am. Okay. Thank you. All right, so give me a second.
Sure.
Okay, here we go. And just to clarify too, Cynthia asked where she landed in that last one. Were we sending gift cards to all the top 3 or just the top person?
So I wanted to send it to the top person, but we're going to see how we can get that situated for all 3 winners.
Okay, all right.
I have to dig in my goodie bag. All right. So everybody, let me know if you can see my screen.
Yes.
All right, so log on to joinmyquiz.com, and the code for this one is 350392. 350392. Dr. Sabria, if you play and you win,
I'm not
you're
playing.
Not winning anything.
I'm not gonna play.
Okay, we can't have any, unfair advantages going on.
No, that's fine. But look, the last time I didn't even know any of those questions, never seen any of those questions, so I don't have an unfair advantage.
Okay. 350392. Let me look and see how many people we have in there so we can get started. I know a lot of people had to jump off, and I'm so sorry, you guys, that we didn't time this better. But next time.
And we got started right on time, too.
We did.
Thank you, Hope.
Joinmyquiz.com, 350392.
Uh-oh, I don't see anybody in there.
Not yet.
No.
See, since I'm not playing, they don't want to play.
I see a whole bunch of us in there.
Do you? Am I in the right one?
19 players.
See, Hope says she sees 20.
Yep, 20 now.
Which one did I have you guys going to? Let me see. Oh man, did I mess something up?
Did you give them the wrong code?
I might did. Let's see. Okay, now I see it. How can I get it started? Let me see. Okay. Let me try this one. I'm sorry, y'all. Okay, let me see if it gives another code. Okay, here's another code. Sorry. So if you can go back and enter the code 689285. 689285. There we go. Ah, there we go. That's better. I wonder what kind of music we're going to get this time. Thank you guys for being patient. I appreciate it so much. All right.
What if the same people win?
What? Let's see. Let's see first. What are CVX codes? Leaderboard. Can you guys see the screen? All right. Look at y'all. Y'all read fast because there was a lot of information in those answer choices. So good for y'all. Next question. Okay, I had to make sure I was sharing the right screen. How do I get out of here?
I'm doing much better this time.
I'm proud of you. Go, Gabby. Gabby's in first place. I see you, B. Next question. Oh, the RHIA. That would support CPC, CPCO, CDIP. Those are mostly coding and compliance. Next question.
I love this question.
Yeah, hopefully we had enough information when people understand what it is. You did a great job covering that, by the way.
I wanted to really talk about it, but since our audience was made up of mostly professionals, I was like, I don't want to bore them.
Exactly. Exactly. Oh, look at that.
Oh, look,
All right. It's all
Taryn
about
creeping up there. She
developing
can't win.
methods. No, you can't win, Taryn.
I know,
Creeping up there.
but it's so fun to play.
Okay, let's see. Next question. All done. Let's see. All right. Look at that. All right. I think we have one more. Good job, everybody. Oh, that was the last question? Oh, next time I'll try to add some more. I didn't want to take up too much time. So, who is our winner?
That was way too fast.
It's me again, but you can give my prize.
I am not giving you another one.
I said you can give my
And
prize.
Terry, there's two people that I can't give anything to. So Bernice, congratulations.
Give it to the next one in the score there.
Congratulations, Bernice, to B. Martinez, and to Whitney. Great job, great job, great job, great job. All right, so now, let me see, let me share the next screen. So we have, okay, can you guys see my PowerPoint?
Yeah, start with the game.
Okay.
We still
Game
can see the game. Yep.
Okay, good, good, good. All right. So Ashley Downing is joining us today from Wisconsin, where she works as an EPIC analyst and a college evaluator. She has spent her career in a multitude of roles, finding that perfect blend of HIM and IT. Ashley spent many years in management as an HIM supervisor, IT manager. Sorry, I got some other things over here. Here we go, IT manager and director of clinical and health informatics. She also held the title of corporate privacy officer, and she's quite a clever discussion today. So Ashley is going to speak with us about what she's seen in health informatics and security since COVID. And afterwards, we can ask any questions concerning certifications or anything about her, her experience. Welcome, Ashley.
Thanks. So I'll just go ahead and share my screen. And let me make sure that we are kicking it off. Okay, so you guys can just see the regular screen, not the presenter screen, right?
Right.
Okay, perfect. So I just wanted to talk a little bit today about the ridiculous impacts that COVID-19 has had on informatics, because it has created entirely new workflows that we never anticipated before. So I'm really excited to dive into the informatics world. You can see some of my credentials there, and I included it here too. I know I'm complicated. I really just love learning. So I started off my career in HIM as an RHIA. I loved IT, so I got the CP HIMS that we'll be talking about later. And then in my career, I also dove into the corporate privacy officer, where I was over IT, so we had some security and privacy. And so I also got the CHIPS one as well. So the areas of focus today, if you take a look at that screen, I'm not going to go over it because we're going to go over it later, but you'll see that I'm a pretty structured person. I really love processes and tools. So hopefully by the end of this, you'll leave with some really great web links, and we'll send it all out and it'll be perfect. One thing to note is I'm not going to talk EHR specific today. So it doesn't matter what EHR or electronic health record you use. It could be Epic, Cerner, or one of the many, many, many others. We're just going to be talking specifically about workflows and scenarios, and how informatics plays into that. So really what I wanted to first discuss is informatics is like the buzzword that has been around for many, many years, but it still seems like not everyone knows what informatics is. So I tried to break it down a little bit by just talking through the different goals. And then there's many, many branches of informatics, whether you come from the clinical side or the HIM side or anything in between. And what we'll focus on today is clinical informatics, but just know that there are a ton of other branches that, whether you be on the revenue cycle, business side, patient access, all of those things need informatics to help bridge that gap between what operations is doing, what IT is doing, and how the two can be really usable together. So really the goal of informatics is to help with patient care. Number one, can we take care of that patient? And how do we do it with technology and make it better for folks? So our role in informatics is really about continuously improving and strengthening those relationships with everybody in healthcare, not only the executives and the physicians, but the nurses, environmental services, dietary, all the ancillaries, pharmacy. So we see everything that goes on in a healthcare organization from the moment that that patient walks in our door until the moment we get that bill and that payment from either the insurance companies or the patient. So we are everything in that line. As I go through the presentation, you'll notice I put some resources. At the end of the presentation, I'll also have a lot of really good resources and sources that you can go click on. And so nothing will be a shock or at all. This is one of my ultimate absolute favorite visuals, isn't it? Right? Like how many people feel like we live in the spaghetti bowl workflow on a daily basis? So one of the CMIOs, so Chief Clinical Informatics Officers, who is an MD. His name is Dirk Stanley. He actually has his own website that I've included down there, but he's also on LinkedIn and he loves doing these cartoons of informatics and bringing it to life. So if you are interested in informatics, you're on LinkedIn, go give him a follow because he creates these things that are just like, that's exactly what my world is like in a graphical format. So what we really talk about informatics is we understand the workflows that when you ask somebody, how do you admit a patient to your floor? They say, well, this person does it this way, this person does it this way, these people tell me to do it this way. I just try and do the least clicks and the same amount, and so I don't get yelled at. That's usually what we hear. So before we come in, everyone's kind of doing their own thing. It's whatever they've learned over the years. We call them magic clickers. They just keep clicking on buttons to try and figure out what else they can break in the system. So some of those are our best spaghetti bowl workflow people. After informatics comes in, what we really want to do is create a very simple start and end point and really create a standardized workflow that says everyone should be able to do these exact same points. And then we would have streamlined patient care, streamlined patient experience, which is huge in this industry. And really that is our goal, to take this jumbled up spaghetti bowl workflow mess and create a really nice, easy to understand workflow that anyone can do. So I thought a picture was worth 1,000 words, so I had to include that one. One of the biggest things that we do in healthcare IT is what's called System Development Lifecycle, or SDLC. What basically happens is it basically takes a process and really puts it through a very specific thing. What we're going to do in the start is just begin to plan. What would this take? What is the effort? What does that look like? We then take that information and we analyze it. Okay, how would this work in the real world? That's great that you say that this takes 3 clicks, but if they want to change that order, now it's about 10 clicks and we're going to get upset users. So we have to analyze that. What we then do is we develop or we build what's actually within the system. And then before it even hits the doors of the production system or the live environment, we test the snot out of it. So that is really one thing that you'll never see behind closed doors. You don't want to know about it, just know that it happens. And we make sure to test out almost every given scenario. And we really do what's called a pass fail. Did it pass or did it fail? And if it failed, we try and go back, clear up the issue, retest it, and make sure that it's live when it goes to the normal users. Then we go ahead and implement that. So we actually communicate, do the training, all that is involved with implementation. And then that last step is really maintain it. Now we've done it, but we have to make sure that it keeps working. And as you can see, the circle is ever evolving. So once we need to optimize it, it goes right back into that plan feature, analyze, develop, test, implement, maintain. So it's supposed to be a constant life cycle using technology in healthcare. So that really is something we'll talk through today as well. Again, I'm really a picture person. I'm very visual. So I would say pre-COVID, the world wasn't perfect, but we were all like Dory, like just keep swimming, just keep swimming. We're doing our thing. It's okay. We know what's going on. And then COVID happened and it was like absolute digital disruption. So what that means is really we had either full EHRs, no EHRs, we had hybrid models, and now we are trying to make people stay home. So what does that look like? And how do we do the most things while saying stay home? And that's really where this digital disruption comes in. And so the full impact of COVID-19, if we were just to sum it up in 4 little bullet points, is really this digital disruption or transformation. So telehealth skyrocketed. If you didn't have to come into the office, we wanted you to stay home. And so telehealth was kind of this nice to have thing, like pulled in your back pocket for, I don't know how many parents are out there, but like Saturday night, like pink eye for your kids, where you're like, okay, you can see the pink eye on my child. Can you get me some antibiotics so I don't have to come into the ER or anything like that at 11 o'clock at night? So we kind of had this telehealth that really was a nice to have. What happened is with COVID, it became almost absolutely essential. So anything that we could do telehealth, we had to really create entire workflows to make that work for anything that we could. Patient portal. So usually with an EHR, you'll have some kind of patient component to that. And what that looks like is the patient has it on their iPhone or their computer, and what they're doing is they might message or schedule or ask a question or do a refill request. And what we saw in COVID, during COVID and even now, is that patient portal utilization increased. If we could talk to our doctors and ask a simple question instead of going in, that was a huge time saver, a huge patient safety, public health safety initiative. So we saw a lot of patient portal utilizations. People were staying home. They were taking care of their elderly family and friends. They were getting those folks on patient portals and making it easier for them. So that was the second part of digital transformation. The third part is if you had someone that you were doing, they were in the ICU, or maybe they were in a mental health or substance use program, and you really couldn't connect one-on-one with them as far as face-to-face, you would have technology. So we might have some type of tablet that we could WebEx or conference or Zoom other families so that they could have that personal touch with their care, even though their family members couldn't be maybe right next beside them. So we also worked with that a lot to get that technology. As you can imagine, infection control was right on us about making sure that everything was okay and could be cleaned and all of that. And then really what came down was a lot of the informatics folks were kind of a hybrid model. You could do some of your work in the office and some of it was on site. And during COVID, what we really saw was it's going to start being, sorry, one sec, previous a lot more telecommuting. So a lot of our jobs became 100% remote. And then that really created a shift in how we support and take care of our users. So from an IT perspective, we usually call the end users, clinicians, physicians, just end users. And so we had to ramp up different things that we'll be talking about later. For helping those people when we couldn't be in the clinic or on the ICU unit and really in person. It became a lot about telecommuting and really building up a way that we could communicate with our users while trying to make sure that everyone was safe. Now, when we move on to the patient scenario, this is where I really love Visio, and this is the most simple one I could do, but we'll talk through 3 different COVID-19 scenarios. Now, again, before this, we never had anything like this created. COVID wasn't a diagnosis that we went through. There was no care path. There was nothing in EHRs before COVID that was like this scenario. So what I'm going to talk about is first the testing needs. So number one, patients need to be tested for COVID for a number of different reasons. But we had to create both an employee as being an organization and for our patients. So we had 2 completely separate testing needs. And of course, occupational health has to be completely separate from their normal chart. And so we had to create workflows for both of those that were very, very different. In the end, what one of the companies did was actually use MyAspirus for their employees to set up self-exams that they would go to the ED, get a kit, they would stay in their car. It's all kind of like a drive up, drive through. They would swab and then send that test back. So no one actually had to go into the hospital, and you had a ton of employees getting COVID tests. So again, we had to create all of these separate workflows for COVID just for testing needs. And then, for example, when we look at the ED or emergency department, depending on where you were and what surge was going on, there could be overflow. You could have huge amounts of people in triage bays. And with all those triage bays, you have to have beds for each person in an EHR assigned so that you can document on them and know where the patient is and where they're flowing. So that just created, kind of a mass protocol for the ED for those surge, and then to triage saying, okay, you do not have any COVID symptoms, you can go do this. You have COVID symptoms, you do this. So it really became about having really specific protocols in our ED to say, this is how we triage, this is where the patients should be staged, and all of that. We also then did antibody infusions. So if they were sick enough with COVID and we could give them an infusion to potentially lighten the load, what we did is we created an entire workflow that was an infusion workflow in the ED, and created that from start to finish, which we'll talk a little bit about what that all encompasses. And then for our ICU or intensive care unit, we had to do, again, overflow. So we were going into multiple units. And then, as I'm sure we aren't alone, but ventilators became a huge thing. We had to know where the ventilators were, in what units, how that all flowed into the EHR, interfacing. And it was just a crazy, crazy time. Still is. I wanted to take a little bit deeper dive into that antibody infusion because whether you're using a popular EHR or you have a homegrown one or you have a tiny one, it doesn't matter. There are activities and things that you know just need to be done. They were done on paper, they need to be done electronically. However you have them, what we really do in informatics is we think about the whole workflow. So we start from registration. What information do we need? We then go into like the actual clinical documentation. So whether that be in flow sheets or worksheets or whatever the system is that they call them, documentation has to be done. You know, what were the patient's vitals? That's really important. What was their SpO2? And so all of those things are flowing in. And then what we need to do is obviously the providers need to have orders placed. So what kind of orders, what kind of panels can we build? How can we make it the easiest way in a system or technology that we possibly can? So then we talked about what medications we'd have to give and how to give those on a MAR or a medication administration record that's online. What does that look like? How should those views be seen? What are contraindications of, well, don't give this infusion if they've had these medications or this kind of thing before? Then, of course, after the treatment's given, you're doing your notes and documentation so we can drop those bills and make those monies. And then we really need to follow up with the patient. We have to give them education. We have to give them their after visit summary or something that says, this is what you need to do next. And so there might be appointments that they need with their primary care physician, or they need to come back for another infusion, or whatever that may be. Those are things that as informaticists, we all take into consideration because it's not just about the patient experience, it's about the end user experience or the providers, the clinicians, the therapists. Everyone involved with their care has to have a really solid workflow so we can get through patients because, especially in those surges, we didn't have time to eat bonbons and read Cosmo. We were doing patient care. So those are some things that we always think about from start to end. What has to be done in order to take care of this patient and get them out the door and on their way? So those are a lot of the things that we tackle in informatics. And we're working with constantly our clinical partners and saying, is this working? Okay, you don't like that order. What orders do you want? And as you can imagine, and as you probably already experienced yourself, with COVID, things were constantly changing. They would say, well, this is the best way to take care of a patient. And then it changed, or a medication wouldn't be available. Okay, if that medication's not available, what is available? So all of those things have to be considered, and it's what we call our workflow. So everything that I've kind of talked about here is what we do on a daily basis. When we talk about navigating those changes, so all these workflows and things like that, how do you actually stay in the know? Number one, research, 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 research. And when you're bored, let's do some more research. So journals, articles, webinars, however we could keep up on an informatics level, we were talking with people. And that's where that networking comes in. Talk with other people, make those connections. Say, how are you doing that at your organization? Or this is really stumping us. How do we get this charge to drop upon infusion? And when it's done, or if it has to have a stop, how do you document that for the coding? So it all really plays into each other. But usually with an EHR, they have some type of user discussion threads, boards that you can connect with other people. My biggest thing working in informatics is I don't ever want to reinvent the wheel. Like someone has probably already figured it out. that works at one of those places where they have all the time and money to do that and they're researchers and that's what they do, I'm going to copy what they do and try and make that for my users. Then what we need to do is plan. Uh, there cannot be enough said for planning, because when you can prepare something, when we had changes that we had to go in front of executives or physician leaders and say, okay, this is what we want to do to tweak our COVID workflow for this. You have to have it really succinct, really clear. It's bullet points for those kinds of folks. What do we want to do? What does it look like now? What does it look like in our proposed future, and how do we get there? So it's all about communication and planning out how to communicate that. And then gaining approval. So I already said that there'll be some sources at the end, but we use SBAR a lot. So situation, background, assessment, recommendation. If you can put your thoughts into that kind of a flow, that usually works really well with clinicians. It's what they're used to from a clinical perspective in some of their notes and stuff like that. So we used communication templates so that no matter what analyst or informaticist was working on it, you'd get that same feel and communication. So again, like I already talked about, if you haven't really dove into system development lifecycle or really know the strategies, there are a million things within each of these circle bubbles that will help you, especially when you're doing the planning and analyzing. And then when we're coming up to that implementation, the communication out. Because we can build the most beautiful things in an EHR, but if we don't effectively communicate that out and train, it doesn't get used. So unless you have a really amazing strategy for all of those items, it will not be effective. And that's what we see a lot, especially in times of chaos and things that were COVID. People were just trying to stay awake for their shifts and working doubles. And I have to get you that information for how to use the EHR when you are exhausted and overworked. So I am not going to write a novel paragraph on this is how you should do this workflow. Here's a screenshot. This is what you need to do. This is why. Boom. And then we would, reiterate to our super users and things like that, in our management structure that could do those kinds of things and make sure that they're being implemented. But again, all of those strategies can be found within that system development lifecycle. So I'll touch a little bit about HIMSS, and I'll touch a little bit about HEMA. So HIMSS is like healthcare IT. It's the piece that gives a little bit different than a HEMA does. They both have informatics, but HIMSS, these are the core competencies that they say, if you want to go into health informatics, these are some things that y'all need to like. And so looking at it from an HIM perspective, we already know a lot of that stuff. A lot of those things are the same things that are on RHIT, RHIA. And so we can use those competencies backwards and forwards. And so if you're a little bit more system analysis design structured, this might be your career path that really jives with you. Basically, you are taking complex information and making it really usable and understandable to people that their normal job is not IT. And the world that we live in, this digital disruption and transformation, it is just a necessary part of the workday. And our job as informaticists is to say, how can we get you to be super efficient at your job while doing what you have to for regulatory purposes? Because that's something we'll talk about later too, is we have to make sure that we're doing the right things for the right reasons. So this is a great option, and HIMSS also has that source bucket on that. They have a great article just on health informatics and how to get into it. Now, AHEMA, this is also on their career map, but informatics on the HEMA side is really, again, about that analysis. Like if you love diving into details, figuring out, we already have to do it in HIM. What are the requirements? What are the regulations? What are the policies? What we're doing is analyzing that and making sure that the IT portion is covering those things so that we're compliant. And being compliant is always good. And so we're really putting that piece of the puzzle together, and we're really connecting those to make sure that people understand what that means. So tips and tricks. I had to throw my diagram in there one more time, but really understanding your workflows. So what is happening today? And I think a lot of the things that people get wrong is that word assume. I assume you're doing what I taught you to do. That is probably the worst thing you can do in informatics or really anywhere in health IT is say, well, I taught you this way, so I'm going to assume that that's the way you're doing it. Because reality hits, and when they're on the floor and somebody mentors them or talks to them, or they clicked 17 different times and found this one screen they love, we want to actually ask the questions to say, let me walk with you on the screen. Let me remote to your desktop and see what are you actually doing. And we can usually get a lot of really good insight into what are you actually doing today. Pretend that you're not going to get in trouble, and we don't have to pretend we won't get in trouble, but you won't get in trouble. Show me what you actually do today. And then we have to do that many iterations because everybody is different. And then we have to figure out what the best solution is. So the end goal, we have to plan that as the future state. And of course, we have to include regulations and policies. Just because you don't like documenting tobacco attestations and whether they are a smoker or a vapor or any of those other ones, the regulations say you have to. So no matter if you want it or not, it has to be in there. And then another thing, especially that came around during COVID, is training. When they forget how to do something, the biggest thing we found was called JIT, or just in time training. So if I want to figure out how to order a COVID panel, how do I do that really quickly? And how do you make it simple so that your online training is easily accessible? So we range from full training lessons where you are a brand new user and we're taking you through the whole class into snips of that class. How do you order a COVID panel? How do you document a note on a infusion? So those types of things where we just quick, less than 2 minutes, are giving them a video demo of what they need to do, because that's about all they have time for if we're lucky enough. So lessons learned so far, because COVID's still very much a thing. But I also love this diagram too, because there's many ways in EHRs to get to what you're doing. There's many different ways to do chart review. There's many different ways to do notes and documentation. So our job as informaticists is to find the easiest way possible and communicate, because if we can save people 2 minutes every day exponentially, every person that gets that kind of success will be able to say, oh, okay, maybe I should listen to that gal from now on. Maybe she does have some good things that I should be working on. So usability is just how easy the system is to use. We're making sure that it makes sense to do it in a certain way. And so are you going to do your charges before you've registered that patient? No, absolutely not. That doesn't make sense. So really the ease of use is finding that maze and doing the straightest line possible. And then during COVID, we also had to have some really good change control. So if something needs to be changed emergently because there's a drug shortage or we're having a surge and we need more beds, we had to have a really good process to say, this is what's happening. This is the communication going out. These are who our kind of communicators are. And then what we did is we created a virtual clinical support line. So I know many people have help desks, but we have a special one just for clinical questions when they get caught up in workflows, so that they get a live person who works with clinical informatics, and they can walk them through workflows. So just depending on what works for your area, that might be an option for you too. So I promised you sources. So I have one source that is just for this presentation that I put together. Then I have bookmark worthy informatics and health IT. So there are many, many different places that are amazing. Places like the Institute for Healthcare Improvement has awesome quality improvement tools that all you have to do is download that form and you just got a template. And so a lot of these different areas and vendors have these types of websites, and also your EHR person should have one as well. And then we'll talk about the certification a little bit later too, but I thought I'd put in some of my favorite privacy and security. Now, I'm from Wisconsin, so I put my Wisconsin DHS, Department of Health Services, and you can always go to yours. One other one I wanted to highlight, if you aren't in Wisconsin, HIPAA. I know it sounds weird, stick with me. They're a coalition of workers that got together and said HIPAA is super confusing, and what happens when you have mental behavioral health and substance abuse, and what happens with your state laws. And so what HIPAA has been trying to do is simplify those things and make really easy templates. And they also have amazing training for absolutely free on privacy and security. So even if you're new to the industry and you just don't even know what a business associate is, those are great things to look. And then of course the HEMA and HIMSS have great websites as well. So we'll open it up now for questions and what I call potential answers, because I can't promise everything. But I put my contact information out there as well. I obviously love this topic and I'm super passionate about it, but if you ever have any questions, even after tonight, just reach out and let me know.
Perfect. Thank you so much. I learned a lot.
That was wonderful.
Yeah, it
Mhm.
was. So I have a question about how you work with the HIM department to make sure that the end users are using, I guess, the protocols and standing orders correctly, if that's an
Oh
area
yeah.
that you're familiar with.
Oh yeah. So we have entire analysts dedicated to HIM specifically. And then just being an RHIA in the IT world, they're really sick of hearing me say, but does that print on your ROI form? So as long as you get it in their heads and their workflows, number one, I think every IT person that I work with that works with an EHR, they better make sure that it can go on ROI. And we teach them what ROI is. In our world, it's not return on investment. In the HIM world, it's release of information. But those are like the communication gaps that we have to go through, is like, no, we're not trying to get you more money. I mean, we are, but it's really release of information that we have to make sure. So we have HIM leaders on all of our different committees. We have them on our change process groups. Anything that happens in the system, they know about it and have a say in it. So when we vet through anything, it always has the HIM stamp of approval. It is so critically important that IT and HIM work together. And I just can't stress that enough. But always get your HIM peeps loving you on the IT side and feel that love both ways. That's what I got to say.
It's quiet. Well, I had another question. So, I know that we're talking about, making the lives of the clinicians easier and less clicks. So, do you guys have it to where you have protocols in place where once the provider puts the order in, then the nurse can automatically order everything without having to get the provider's permission?
Yeah, so it just depends on the situation, what they're ordering, and all of those. But we have different protocols. like a set of orders
Mhm.
that we can say, okay, if we know that this person is coming in and this is what they need to do, we have a protocol. It's been approved by physicians, and it's been regularly from a CMS regulatory standpoint. 3 years, every 3 years, actively reviewed. Those are what we call order sets,
Yeah.
that we can automatically go ahead, order. It goes for a cosign, sometimes depending on what protocol you're doing. But yeah, we want to get that patient taken care of. If we know the right things to do, that's what we call a care pathway, and we're going right in.
Nice. Thank you.
Yeah.
Anybody else?
Cool. Thanks.
Well, I do. Now that nobody else has a question, Ashley, in what way would you say that you use your credentials in your work?
Oh gosh. Yeah. Every day.
Okay.
Every day I pull in my RHIA hat where I'm asking, is that going to print for release of information? Is that legal? Is that
Right.
compliant? Are people actually going to do what I build? Because again, like I said, I could build the most beautiful thing in the world, but if it isn't vetted properly, it isn't communicated right, nobody uses it, it is absolutely useless. So from an
Mhm.
RHIA standpoint, I am making sure that we are compliant and happy, and all I want to be able to bill it. What can we charge? How can we charge? When an infusion drops, start, stop times, all of those things go into that. So we're thinking about coding and all of those items in our daily work. As far as CPHIMs, working in healthcare IT, they teach a lot of that SDLC, or that system development
Mhm.
life cycle.
Right.
So I am using that constantly. And then CHPS, or the privacy and security, when you're working with technology, having privacy as like one of your first thoughts is so important to the integrity of our AHIMA code of ethics and the
Right.
other ethics that we use. It's not about data to us. We can plug in numbers all day long. It's really about, this is the patient's information. What's going to go out on the patient portal? Have they already been talked to? Making sure that cancer diagnoses are talked about before that information is released. Those are things where we try and make that humble and human. So one of my favorite quotes from one of the AHIMA um, health, health information professional week was keeping health information human information.
Yep.
So that's something
Hmm.
that we really try and do from a privacy standpoint is, this information that we're seeing on a daily basis is somebody. It's your grandma, it's your grandpa, it's, you know, tug on those heartstrings. They are
That's
people,
right.
and we can't just willy-nilly be sending out stuff. And so all of my compliance peeps really appreciate my CHIP certification, and I get lots of, can you find this audit for me? What did this person do? And even running audits for compliance, making sure that, this is just my job. I happen to know this information, and at the end of the day, I am an amazing secret keeper, because that's just my job.
Well, thank you. That's
Yeah.
the only question I have. Do we have anything else in the audience? All righty. Well, thank you so much, Ashley. Is it safe for me to take over?
Yeah, you bet.
All right. Well, thank you. So, this is Kenja here. We are going to talk a little bit more about the credentials that Ashley has and answer whatever questions you have about those credentials in particular. So let me share my screen. Hold on. Hold on. I'm a little lost here. There we go. All right, can you all see my screen okay?
Yes.
All right, thank you. Mariah, are you there? Mariah is
I
joining us.
am.
Hi, Mariah.
Hello.
She is going to give us the rundown on the CA HIMSS, the CP HIMSS, and the CHIPS certifications. And then if anybody in the audience had any particular questions about eligibility or anything else that you're wondering about the certifications, we will be glad to answer them for you.
Okay. So for the HIMSS credentials, the first one we have is KHIMSS, which is the Certified Associate in Healthcare Information and Management Systems. So just to go over a little bit about this is the requirements to sit for this exam is to have a high school diploma. The CEU requirement that you have to maintain, so continued education units, in order to maintain your credential would be 45 CEUs. And of course, there's different costs associated with the cost of the exam, whether you are a member or a non-member. Regular membership to sit for the KHIMSS is about $199. And then non-member would be $359. In KHIMSS, the certified associate one, that's like your beginner for HIMSS, and then transitioning into the certified professional in healthcare information and management systems. That's the one step above the first one. And the requirements for that one, you have to meet one of the following eligibility requirements. So either hold a bachelor's degree from an accredited college or university and have 5 years experience in information and management systems. 3 of those must be in a healthcare setting. Or hold a graduate degree or higher from accredited college, university, and 3 years experience in information and management systems. 2 of those must be in a healthcare setting. Or finally, have at least 10 years experience in information and management systems, and 8 of those must be in a healthcare setting. The CEU requirement to maintain for this credential is the same as a KHIMSS, so it is 45 CEUs. And then the difference in cost of exam, whether you're a member, is $399, and then a non-member is $549.
Wow.
It's the HIMSS credentials, they're very specialized credentials. So
It's okay. It is.
Yeah.
It is. And it's definitely an investment.
It is an investment, and I think it's a good investment if you're really into HIM and you're like a long-term career person. It's one of those where I see a lot of people who've spent at least 5 years in the field and decide to go for some additional credentials. So it is an investment. Some people that take an interest in. And then the other one offered by AHIMA, the Certified in Healthcare Privacy and Security, so the CHPS. This one, for requirements, you have to meet one of the following: a high school or general education degree and a minimum of 6 years of experience in healthcare privacy or security management, or an associate degree and a minimum of 4 years of experience in healthcare privacy or security management, or CCA, CCS, or CCSP, or RHIT credentials. So those are other AHIMA credentials that you would have to hold, including a minimum of 4 years of experience in healthcare privacy or security management, a bachelor's degree and a minimum of 2 years of experience in healthcare privacy or security management. There's a lot of ors here. Or RHIA and a minimum of 2 years of experience in healthcare privacy or security management. And then finally, another option is having a master's degree or higher and a minimum of 1 year of experience in healthcare privacy or security management. The CEU requirement for the CHPS is a little bit smaller than the HIMSS, is 30 CEUs. And then the cost for the exam, if you're an AHIMA member, is $259, and the non-member is $329.
All right. Thank you for that, Mariah.
You're welcome.
Something that I do want to point out about the CHPS, the CHIPS exam, is that in 2020, the pass rate, I want to say was, well, never mind. It wasn't the pass rate. I'm thinking about total. So typically AHIMA outlines how many or the pass rate for the national exams. But for this exam, I don't think they did. They just provided you with the total number of test takers, if I'm not mistaken. Oh, okay. So yeah, they had 57 first-time test takers and the pass rate was 53%. I've heard that this exam is pretty hard.
Yeah.
So yes, that's why I would always encourage a workshop, an exam prep course or something like that prior to taking it. I remember, currently in my office for this exam, I have not only the exam prep guide, but I think I have 4 different privacy and security books that I recommend for those taking this exam. So does anybody have any questions about any of these credentials that we can help answer for you tonight? Okay, I know we're all tired, but
It's hump day.
it is. But we appreciate all of you being here. If you have any questions for us, please do not hesitate to let us know. Or please reach out to us. For more information, you can visit us online at www.the-qualified.com, or you can email us at getcertified@the-qualified.com. I hope that you found this session to be helpful.
Me too. And thank you so much, Ashley, for that wonderful presentation.
Yes, that was fantastic. Thank you.
Yes, thank you.